Good morning, all. Today is the 12th day of April, and we are all welcome to the workshop for today, conducting rehabilitation assessments. We'll be having 4 speakers today, be from the P&O, prosthetics and orthotics, that's Dr. Chikwado. Then the second speaker will be representing occupational therapist. He is an occupational therapist. The first speaker also is an occupational therapist, business therapy. Then the Mr. Anjari, he will be speaking. Would have as a team. We hope to move the rehabilitation forward with our assessments. I think we should with more participants, Dr. Chikwado, because of essence today, because we have 4 powerful speakers for us today. We have to just manage it as you listen. Dr. Chikwado, over to you, sir.
Okay, hello, good morning, everybody. I am Dr. Chikwado Kingsley Onwukamuche, a chief prosthetist and orthotist from the Federal University Teaching Hospital, Owerri. I'm as well an adjunct lecturer in some universities in the P&O department. So this morning, I am opportuned and humbled to be facilitating this webinar on conducting clinical assessments. So give me a moment, let me share my screen for us to commence. Okay. Please, can I get an affirmation that this screen is being shared and seen by all?
See your screen.
Okay, you can see it?
Yeah.
Okay. Thank you very much. Okay, so I'm actually taking this part of the program from a P&O perspective. I'm made to believe that the other facilitators are also taking it from the perspectives of the various other professions under the medical rehabilitation. So conducting rehabilitation assessments. Okay, so these are the content as we are all aware. I will try to hurry because I have quite a lot of work to present here. So you permit me, I'll try to rush through, knowing, because I wouldn't want to venture into the time allocated for others. So as we all know, P&O plays a crucial role in assessing and providing the care for individuals who require prosthesis or orthosis. And this includes assessing, prescription, designing, fitting, monitoring, educating patients regarding the use and care of their appropriate O&P devices. They are therefore responsible for completing accurate clinical assessment before they can embark on all these things. So in the clinical assessment, some of the factors that we'll consider will include the weight, potential level of activity, the intended use of prosthesis or orthosis. These information are documented and these are documented, and there are evidence-based tools for carrying them out as part of a clinical assessment. So the first topic here is potential sources of information gathering, especially as it pertains to clinical assessment. Information gathering is important, as we all know, and forms the basis for formulating provisional diagnosis and treatment plan, not just in P&O, but in every medical profession, and in fact, in every aspect of life. So the primary goal of information gathering is to understand the state of health and determine if the information we are gathering in the first place is relevant to the person's complaint and the prescription of treatment thereof. For instance, a patient or an individual that is referred for P&O management that has diabetes mellitus, high blood pressure, elderly, history of stroke, might be managed differently under different presentation, under different information that is gathered. On the secondary aspect, the goal is to ensure that the information that we are gathering will help to avoid potential harm to the person that we are managing. For instance, again, a person that is prescribed or referred to a P&O professional for ankle foot orthosis prescription, but has fluctuating edema, or a person referred for flat foot management, but has diabetic foot neuropathy. You see that under these other conditions, the way we manage these patients will differ. The way an orthotist will manage somebody with flat foot and also has diabetic neuropathy will be different from the way he will manage a person with flat foot but has no diabetic neuropathy. So getting information on the condition of the patient is very important in directing our formulation of treatments. Yet another goal is to gather information that can direct our P&O intervention because it indicates the person's needs. It also helps in our referral from our own intervention to other professionals. So based on information gathered, we can now say, okay, having intervened or not, we can now refer the patient to physiotherapist, to the occupational therapist, to the audiologist, to the speech therapist, and so on and so forth. It also helps in material selection as well as design modification of P&O intervention. Information gathering forms the health history of an individual. These health histories are mostly subjective as opposed to objective because most of the information are coming from the patients and they are biased as far as we are concerned because it's based on the personal experiences of the patients. But they can provide information on the functioning and unmet needs of the person that came to us for intervention. Therefore, sources of information for information gathering will include the primary sources. The primary source is the patient himself or herself. So the patient or person is the primary source of information gathering, while the secondary source will now include the referral notes with which the patient presents to you, the patient chart, especially if it's an inpatient. So the patient folder as well as the chart will also give us, provide a source of information. Patient relatives can also provide a secondary source of information. When we consider patient relatives, the patient relatives that are providing secondary information or secondary source of information should be a legal care partner of a person. So who is the legal care partner of the patient? For spouses, the spouse should be the legal or care partner of each other. So the husband is the legal partner of the wife and vice versa. Adult children are care partners of their aged parents. Parents are care partners of their children, and so on and so forth. Care partners may contribute information that are very important to the health needs of the patient, especially when the patient, him or herself, might not be able to provide this information. Or when the patient forgot one or two parts, the care partners can help provide those important parts. If information is obtained from other source other than the care partner, it should be well documented and the source should be well defined for them to count. So what are the types and purpose of information that we are collecting or recording? This workshop is not focusing on documentation, so it's not in the scope. So we are focusing on information gathering as well as assessments. On initial consultation with the patient, informations like demographic and health histories are usually gathered. Subsequent visits may require a review of this health history, as well as an update with changes over time. So what are the health histories? They entail inquiries into the patient's chief complaints, the patient's past medical history, social history, family history, and so on and so forth. Chief complaints will state in the patient's words why the patient is here or there to see the professional. For instance, I have a limb deficiency, I have a pain, I have a stomach pain, I have a knee pain, and the rest of them. So I came for limb prosthetic intervention or orthotic intervention. Medical history on its own entails an in-depth inquiry into the patient's needs, as well as patient's medical, surgical issues, including diseases, ailments currently treated, and those that have effect on patient health. Okay. Then we talk of family history, social history, allergies. What are the potential allergies that the patient has or that the patients know about? Okay, some people might be reactive to POP. Some people, especially POP inhalation. Some people might be reactive to polypropylene or any other plastic that is used in piano, especially those that they have history of, those that they can tell you so that they can be avoided. Then we also do a review of systems as a part of information gathering from the patient's perspective. So what do we mean by a review of systems? We say we gather information on patient's history not already provided across the relevant organ systems of the patient. So the review of systems helps us to gather information on possible new problems not provided by the patient, but could be inferred from what the patient has already provided. For instance, when the patient complains of pain radiating down the lower limbs, radiating down the knee to the ankle, we can, based on that radiation, try to gather the history of spine trauma or a history of spine interventions that has been provided to the patient in the past. So that can give us an idea of maybe whether there is a complication coming from somewhere causing that, whether there is a primary cause or risk factors associated with the chief complaint of the patient. Mind you, most of the patients that are coming to you, to the P&O professionals for P&O services, always think, or mostly think, that P&O is an artisan work. Therefore, history gathering, these people will think that history gathering is not necessary. For instance, there are times patients will come and you want to clerk or document, or you want to gather information, and they'll tell you, are you not just provide it, give me this thing, let me go, give me this thing. If it's an issue like name length discrepancy that requires a shoe raise, should be assessed. But most times they'll say, just work on my shoe, let me go. So you should be able to explain the importance of history. They came with a chief complaint, but you have to make sure that that chief complaint is actually what needs to be intervened in and not an underlying issue. So indications that a person is in need of protection measures. This is actually important, although it's not rampant in our climb here. In clinical assessment, identifying when a person may require protection measures is very crucial in ensuring their safety and well-being. Demonstrating concerns for patients' safety will foster trust, therefore encouraging the patient to open up to you more. Because information history or information gathering can actually help to determine your direction of intervention. So therefore, getting the patient to trust you or relax with you is very important. Some patients will come with a whole lot of psychological baggage. We should be able to clear those baggage. Those that are in need of protection, you should ensure that the patient's overall well-being, including his physical, emotional, and social health, is considered. So what are some of the signs or some of the indications that the person might be in need of protection? A person that came to you for prosthetic or orthotic intervention may have any of these signs that can make you to say, okay, this patient needs protection. So one of them includes physical signs of abuse or neglect. Others include behavioral indicators, vulnerable circumstances as documented here, environmental risk disclosures or a report where the patient directly tells you about abuses or neglects, or report from family member that such a patient is having such abuse or neglect at home. So what should you do in such a situation? So protection measures in clinical assessments are action taken to ensure the safety and well-being of individuals, especially those who are vulnerable or at risk. So they include immediate safety actions like removing the individual from harmful environments or providing emergency medical care or shelter. Others will include reporting concerns to authorities like the police, the social services or law enforcement, implementing legal protection like restraining order or guardianship. Others will include supportive services, offering psychological support, connecting individuals with community resources like housing or financial aid, as well as monitoring and following up. So after providing these protective measures, you need to continue to monitor to follow up to make sure that this patient, the protective measures you have taken are still being implemented. Now, these protective measures, in as much as they might be feasible in our climate, but their implementation depends on several factors like infrastructure, awareness, and resources. For instance, Nigeria has laws and policies aimed at protecting vulnerable persons. Such laws include the Child Right Act, Violence Against Persons Prohibition Act. So we can utilize those. However, limited resources and funding for healthcare and social services might hinder the effective implementation of these protective measures. And this is why these measures, these protective measures, are not well utilized. So you don't see most people implementing them, okay? Maybe for fear of their own, of themselves, I mean the professional here, or for lack of funding to implement them. So to this, we recommend strengthening collaboration between government agencies, NGOs, and community organizations to enhance the feasibility of these protective measures. Because I can tell you that unless I stand to be corrected, they are mostly not feasible, mostly because of lack of funds. Then there is need to increase public awareness and education about the rights and available resources that can empower individuals to seek help. In fact, the bottom line is that Protective measures are provided, and if they are to be provided, they must be provided under sound legal framework. So the professional must be aware of what he's doing before he commences. As a professional, we must be aware of how to provide this. We must understand the feasibility of providing them before embarking on them. Most people will come to you with amputations for rehabilitation. And when you try to find out the cause of the amputation, the reasons are not clear or pointing towards abuse. Like there are times when an amputee came to me many years ago for prosthesis. During their assessment, it was discovered that the younger brother, uh, not from the same mother anyway, uh, cut off the limb with a knife. So what do you do in such a situation? Report to police? What happens after then? So the professional must be aware of the legal framework that are available, and to be make sure he has to also make sure that there are assistants protecting him from having a rebound from the person that caused the issue in the first place. Methods of assessment, and we'll be discussing testing, measurement, and evaluation. So when we say testing, we mean the use of standardized tools or procedures to assess specific attributes, abilities, or conditions. Okay, these tests help in diagnosis of conditions. They help in measuring cognitive abilities, as well as evaluating emotional functioning. So you can see in the pictures here, the clinician is measuring the range of motion at the ankle joints, testing, rather not measuring, testing the range of motion. In other words, the other person is testing the alignment of the prosthesis, and in the other one, the other person is testing prehension ability of this person. So the tests include pressure mapping test, range of motion test, muscle strength test, circuit alignment test, outcome measure test. These are some of the things that we utilize in our P&O interventions. So they help us to test. Just like patients come to medical doctors with one condition or the other, and the doctor sends them to for medical laboratory tests. In P&O, these are some of the tests we do in order to understand the condition the patient is presenting with. There are many, many more of them spread across the different interventions we offer in P&O. Measurements, on the other hand, refers to the process of quantifying. When we are running a test and we're actually quantifying, because the ordinary test might just be the process itself, but the measurement will now entail quantifying the parameters of the test, quantifying the attributes, the behavior, the outcome, using scales, metrics, and instruments. So when we say measurement, we don't just mean using measuring tape, using goniometer, these are physical tests and physical measurements. We can also measure the people's behavior. We can say somebody's behavior is outrightly condemnable, and we can assign a value to it. We can measure an outcome. We can measure an attribute. We can measure normally metrics. We can measure scales. We can measure outcome using scales, metrics, or instruments. So scales will now be when we are assigning a value to attitudes, to attributes, to behavior. Metrics is when we use our physical measuring devices as well as instruments. Measurements provide a numerical data that can be analyzed and compared. So we have a test that describes how we conduct or how we assess or how we perform some measurable activities. Measurement itself provides a numerical backing to this test. Okay, while when we talk of evaluation, we'll now see that we are now analyzing or comparing. So these three things work hand in hand, one comes after the other. So examples of some measurements we perform in P&O include anthropometric measurement like limb length, foot length, body segment circumferences, as well as diameters, including anterior, posterior, and mediolateral diameters. Other tests that we do include alignment measurements, other measurements, sorry, that we perform include alignment measurements like joint angles as well as device positioning. During alignment, we try to check the position of one component relative to the other. So these relationship between components are either with respect to joint angles, the angle between them, or the position. Some devices will be positioned anterior to the other ones. Some might be positioned in 15 or 20 degrees flexion or extension with relation to the other ones. We also measure pressure distribution, where we can measure actual pressure, we can measure forces, we can measure gate variables, okay? So this is very prominent, especially in the management of diabetic foot, where we try to find out areas of the plantar surface of the foot that has high pressure, and we try to use our intervention to offload those pressure or redistribute those pressure, because those high pressures can actually lead to tissue destruction that can lead to diabetic foot ulcers. There are also some functional measurements that we perform, especially gait analysis, where we can measure the step length, the stride length, the cadence, the step width. These are very important in P&O interventions to know how we can perform our alignment. Other functional measurements will also include range of motion. Under performance metrics, we can measure things like timed walking test, timed up and go, balance test, and the rest of them. Then in measuring behaviors or attributes, we can measure patient-reported outcomes, where we measure people's responses to some activities that we have posed to them. So measurements usually have physical or virtual tools used to measure them. So for there to be a measurement, there must be a tool, whether that tool is physical or whether that tool is just virtual. Virtual in the sense that you just ask the person a question, and based on the response, you assign value. In fact, you create a range and then assign values to them. Those are also measurement tools. So such measurement tools can include tape measures, vernier caliper, goniometer, force plates, alignment jig, as well as outcome measurement tools. These are some of the measurement tools we utilize in P&O. On its own, evaluation in as far as P&O is concerned, involve the interpretation that is gathered through the test and measurements we have performed, and helps in making informed decision about the device design that we are going to make, the fitting, and the effectiveness of the fitting. Okay, so evaluation is simply bring the test, bring the measurement, what did they say about this patient's complaints? What does it tell us? And how does it inform our clinical intervention as P&Os? The aim of evaluation is to assess the functionality and the comforts of P&O devices. It also helps to determine the impact of the device on the patient's mobility, on the patient's independence and quality of life, as well as helps to identify areas for improvement in the device design, as well as the device usage. Okay, these are some of the aims of evaluation. Some examples that are highlighted here include in gait analysis, where the evaluation of the working pattern of an individual can help to assess the effectiveness of a prosthetic or orthotic device. So most times when we fit our P&O devices, and during the time we are performing dynamic or static alignment, we are trying to do, or we're trying to see from the gait performance of this patient, is the alignment okay? Are the components connection to each other optimal for the patient's performance. Hence, we measure metrics like stride length, cadence. We also check symmetry, which is in form of balance, to be sure whether the alignment is optimal for this patient or whether we need to remodify the alignment. We also check for the height of the device in comparison to the sound limb to know whether there is limb length discrepancy as well as other parameters. Also, we utilize outcome measure tools like prosthetic evaluation questionnaire, PEC, as well as the OPUS, orthotic and prosthetic user survey, to gather the information on or information or feedback from patients' performance using these devices to help us to evaluate the patient's comfort, the patient's usability, as well as the impact of these devices on the quality of life of the patients. We also use things like timed walking tests, like the 10-meter walk test, the timed up and go, to evaluate mobility and endurance. Other outcome tests like the amputee mobility predictor scale, not mentioned here, is used to determine whether a patient can even use a prosthesis in the first place, as well as the prognosis of prosthetic usage as time goes on. Measuring pressure distribution is another important one, where these are measured on the residual limb or foot to evaluate and ensure proper fit and avoid discomfort or injury. The same pressure distribution has been utilized in socket comfort, socket skin pressure distribution in the fitting of the sockets to the patient to determine that the best fit is obtained. So in this case, we utilize a socket pressure device or measurement device to know whether the socket is tight or loose. We also try to measure the pressure at different aspects of the stump to determine if our socket is actually good, because most times the patient can only give you an analog response of whether, okay, the prosthetic socket is good, it's tight, it's loose, but we most of the time require objective responses in order to be sure of the accurate outcome of our intervention. So in such instances, measuring the socket pressure is also very, very important. Okay, so we talk about psychometric properties of these assessment tools that we've been talking about, especially as they relate to piano. Psychometric properties are the characteristics, properties, as well as qualities of the assessment of an assessment tool that determine their reliability, their validity, as well as overall effectiveness in measuring what they are designed to measure, or in measuring what we want to use them to measure. Take, for instance, we might have a measuring tape. We can't use a measuring tape to measure an angle. We can't use a goniometer to measure maybe stance time, okay? Because it is not reliable, it is not valid, and it is not effective in measuring that. In piano, these properties are critical for ensuring that the tools we use provide an accurate and meaningful data. So we can even ask a question. Why is a tape rule used to measure the length of the foot, but not range of motion? Why is cadence used to measure or estimate gait speed, while step length cannot? So there are properties that define each of these tools and what they can measure, and those properties are called psychometric properties. These properties, therefore, include validity, which describes the extent to which a tool will measure what it is intended to measure. For instance, in the example we gave earlier, a pressure mapping system should accurately reflect the pressure distribution on a residual limb. It should be able to measure it accurately. If it cannot, then it's not a valid. Therefore, a measuring tape is not a valid tool to measure pressure distribution of an individual, because it cannot accurately reflect that measurement. Another psychometric property. There are different types of these things. There are different types of validity. Well, that is beyond the scope of this this presentation, mostly because of time. Okay, responsiveness on its own is the ability of a tool to detect meaningful changes over time. Can a measuring tape be able to detect stump volume fluctuations during prosthetic usage over time? For instance, most patients that come to us as prosthetists for limb prosthesis, on their first contact or first assessment, you measure and you find out that the stump is swollen, or the stump is cylindrical, or the stump is bulbous. What we normally do, we don't just feed the prosthesis immediately. We start performing a stump compression procedure aimed at reducing the volume of the stump. This procedure helps to prevent an immediate replacement of the socket in a short distance, a short space of time. Because if we should go ahead and fit the first prosthesis immediately without stump compression, then you are sure that in the next less than 1 or 2 months, this patient will come back to you with a complaint that the stump is now wobbling inside the socket because of stump shrinking. So what we do is that we start with stump compression within some weeks or months to make sure that the stump reduced to a significant volume before we fit our prosthesis. Now, how do we now determine that the stump has shrunk? It's by measurement. So how able is the measuring tool that we are using, which is mostly a measuring tape where we measure the volume, the circumference of the stump? How able is the measuring tool, how able is it to detect those changes in stump volume over time? The patient might come on the first day and you got a circumference at the distal part of the stump to be like 20 cm. In the next 1 week, you measure and you are able to detect a reduction of 2 cm. Upper week, you got a reduction of 1 cm. The ability of that measuring tool to detect this minor, small stump fluctuation volume is called responsiveness. And there is a clinical term that is used to represent responsiveness, which is very important and which can be used to interpret such data, called the minimum clinically important difference, MCID. Is an important clinical tool that is used to compare pre and post-intervention scores to know whether our intervention has made a positive impact or not. In other words, outcome. So MCID, as we'll see later, is an important outcome measure. Reliability is another important psychometric property of assessment tools in P&O. Reliability talks about the consistency of a tool to produce the same results under similar conditions over time. So imagine that you use the measuring tape or maybe a weighing scale to weigh the weight of a patient today, or because of weight fluctuation, let's not use that. Let's say a measuring tape, use the measuring tape to measure the length of a table today, and tomorrow you measure it again. The ability of that tape rule to give you the same reading over time is reliability. It also has different types. We have the inter-rata, intra-rata, and the consistency and the rest of them. That also is beyond the scope of this presentation. A goniometer should consistently measure ROM across multiple trials, whether it's inter-rata or intra-rata. And based on this, we can now say that the measuring tool or device should be able to avoid errors of measurement. Based on that, we now have another clinical important outcome measure called a minimum detectable change. It's a closely related to reliability of an assessment tool. It's actually the minimum amount of change in a patient score that ensures that that change is not the result of measurement error. Most times you can measure something and then remeasure again and get another reading, and that reading is because of an error in your measurements. So, and the ability of a measuring tool to report the same thing over and over again will therefore show that the minimum detectable change is as low as possible. Okay? So it tries to identify the standard of error, SEM, standard of error measurements. So when the standard of error measurement is low, that means that the reliability of this device to measure an outcome is high. Other ones will include sensitivity and specificity. So why sensitivity is the ability of a measuring tool to correctly identify individuals with a condition, the ability of a tool to correctly identify individuals with a condition. Specificity, on the other hand, is the ability of a tool to correctly identify individuals without that condition. So that means that a measuring tool should be able to have both sensitivity and specificity. So a diagnostic tool, for instance, for limb alignment should accurately identify misalignments. The Pirani score that we use in clubfoot management, pediatric clubfoot management, should be able and has been shown to be able to identify both individuals with and without congenital Talipes equinovarus CTV. There is also the interpretability as a psychometric property of assessment tools. These parameter or this tool or this property entails the ease with which measurements can be understood and applied in clinical practice. The ease, how easy is that measuring tool? How easy is it understood? In other words, complex measuring tools might be very complex to be implemented or even understood, and therefore their applicability in the clinical practice might be limited. While easy to understand tools like the numerical rating scale, the socket comfort score, provide clear thresholds. They are very easy to use. They have just short time. They are short time, okay? And they are very acceptable among clinicians. Then we have feasibility. So in feasibility is very close to interpretability. So it means the practicability of using a tool in a clinical setting, considering factors like time, cost, and required expertise. So it's almost very related to interpretability. Measuring tools that are expensive will be shunned or avoided by most clinicians. I was aware that the British Association of P&O had to come together and adopt some outcome measurement tools for use in British P&O. And one of the major consideration or one of the factors considered was cost, as well as time, and then expertise. So they're able to adopt the numerical rating scale. They adopted the socket comfort score. So you can see that these two scales, among others that they adopted, are free of charge and also have limited time to apply. Just highest within less than 1 minute, you are done. Then the expertise, it's not complex. So for instance, a first place system could be user-friendly okay, it could be digital also, and not overly time consuming. Just the patient stands there, you get your reading, the patient comes down. But however, due to cost, they might not be feasible for a P&O clinic in our client. Okay. Another very important psychometric property we'll talk about is ceiling effects. So the ceiling effect is a property that occurs when a test or assessment tool cannot measure higher levels of performance because it has an upper limit. When a tool cannot measure, for instance, we have our tape rules now. Most of our tape rules, or let's say vernier caliper, most of our vernier calipers, especially the smaller ones, are rated to read from 0 to 150 mm. There are also ones that can read as much as up to 600 mm. Now, if you are measuring most pediatric population, this smaller vernier caliper can measure it efficiently. But if you now want to measure adults, bigger individuals, you see that the upper limit of these smaller vernier caliper cannot capture the higher limit or the higher measurement, bigger measurement that you can find in adults. So you can say that the smaller vernier caliper will have a ceiling effect when we are talking about adults. So patients who, another example, especially in attitude measurements, patients who perform well and exceptionally well may all have or score near to maximum for a score. For instance, very good. So very good here might capture those that have well and exceptionally well. But if you want to separate, if you want to get the actual figure using maybe a measurement tool that only stops at very good, there is no very, very good to capture those that are exceptionally very good. You only end up in combining both populations of well and exceptionally well. You will not be able to differentiate them. So in other words, such a measurement tool that cannot cover those that are the upper limits of measurements are set, cannot be captured. Also, a mobility test with a maximum score may not capture the progress of highly active prosthetic users who exceed the test upper limits. So you see that that becomes a problem because both those, okay, now let's also utilize a grading score that we give to in examinations. We say that 70 to 100 is A. So when that somebody has 70 is A. If he has 75 is A. If he has 80 is A. You see that this type of scoring has a ceiling effect because it doesn't try to appreciate those that have 80 or 90 or even 100. So if there is a way you can now say, okay, those that have 90 is A excellent. Those that have 80 is A plus. Then you will now take care of the ceiling effects. On the other hand, floor effect is now the opposite. If the limits of a measuring tool cannot capture those at the lower limits, then it becomes a problem. For instance, let's use our thermometer. Sorry, I'm digressing away from medical rehab. Using a thermometer, most of our thermometer, especially the one we use in the clinic, can only have 0 as the lower limit. But we know, you and I know that there are temperatures that can run into -4 and -10, especially in climes like Canada and the rest of them. So you see that such a thermometer might not be able to record or represent well those are the lower limits. So that becomes a problem, and that is called floor effect. These psychometric properties ensure that assessment tools in P&O are effective, reliable, and applicable in real-world clinical settings. So whenever we are trying to adopt any assessment tool, we have to make sure that we understand the psychometrical properties of that tool to be sure that it will not leave us hanging in the middle when we start embarking them. Imagine that you are performing a clinical research and you are using a particular assessment tool, and all of a sudden you see, you find yourself in the, you spent a whole lot and you get a point that you cannot proceed further because the assessment tool that you are using or the measuring tool you are using can no longer capture the level of the readings that you are getting. It becomes a problem. So there is need for us to always ensure that we understand the psychometric properties of the assessment tools that we are using to know whether it's feasible, to know the ceiling effects. We must know the floor effects. We must know the validity, the reliability. And these informations are in evidence-based. They are there. They are there. So make sure that we consult. There are evidence-based psychometric properties for amputee mobility predictor scale, for socket comfort scale, for numerical rating scale, for our outcome measures, whether it's performance or patient reported. There are clinical evidence-based for the psychometric properties of all these things. We have to make sure we adopt them. We have to make sure we see them, study them, understand them before we adopt. Impact of health, personal and environmental factors on assessment results, especially as they relate to piano. There are many factors that can relate with the clinical assessment outcome that we got that can affect the measurement outcome that we get. When you measure the limb, the length of a stump or the length of the foot of a patient, and you got 20 cm, there are factors that can affect you and you make a mistake and you get maybe 15 cm. There are factors that can make you and maybe you get more than, you get like 20 cm. Imagine also you are measuring the curb angle where you need to be, curb angle of a spine, of a scoliosis, where you need to be very accurate, position your rulers or whatever, and you are not just following up. There are interferences from here and there. You end up not getting the accurate reading. Imagine also that you are weighing a patient. You are measuring the weight of a patient on a weighing scale, or you're measuring the height of a patient, okay? And then there are these local disturbances, as we are going to mention. You'll see that the reading will be different. If another person comes and the person is calmer than you were, the person will get another reading, and there will be inter-rata differences. Okay, therefore you can now say that the inter-rata reliability is poor or low, but is actually from factors that are locally disturbing the process. So what are these factors? The factors can be personal, they can be health related, they can also be environmental factors. So the factors can be personal, like I said, from the clinician part, can also be from the clinician himself, it can be for the patient, it can be social, it can be environmental, as well as health. Personal factors will include age, gender, literacy, economic, activity level, developmental delays, physical disabilities, sorry for the repetition. So we all know that in terms of age, newborns and elderly people have different attitudes during measurements. Newborns, you don't expect them to respond to questions, to give you any response. You can take your measurements if they allow you, if they are not kicking their feet and the rest of them. So you have to understand that, and therefore you not expect them to give you a response, but their care partner. Okay. While elderly patients that are having some disabilities, you might not get an accurate measurement because of the disability. Okay. For instance, range of motion in a person that has a contracture, joint contractures, might not give you the full range of motion. So you have to know that because of the presence of some disturbances, like physical disabilities, I am not getting a good, what I should get. So understanding the personal factors as they are interfering the patient's life is very important. Other physical or personal factors, include the test administrator's demeanor, the clinician's demeanor, the attitude, tone, and body language of the clinician can create a supportive or intimidating atmosphere that can impact on the measurement. Language difference, ethnicity, cultural differences are also personal factors too. When the clinician that is posing the question or taking the measurement is not speaking the same language with the patient, there is already a problem. And that's why in some clients where this occurs, there is an interpreter. When they are of different ethnicities, especially where a tribalism is the case, where somebody from ethnicity A stigmatizes somebody from ethnicity B or discriminates against them, it becomes a problem also. Health factors are also their illness, fatigue, hunger. Somebody that is hungry, whether it's the clinician or the patient, cannot be expected to cooperate during measurements. Somebody that is sick, especially those with communicable diseases, will be stigmatized or discriminated. That will affect the measurement outcome. Environmental factors are also there. We have room temperature. When the temperature is higher, it creates discomfort that is affecting concentration and performance. Concentration on the part of the clinician that is applying the measurement, concentration on the part of the patient upon whom the measurement is taken from. Noise levels, when the noise is high, they can't even hear themselves to know what they're doing. When the lighting is poor, it affects the reading of the measurement outcome. Some patients are quite shy and therefore might not cooperate very well in some measurements in the presence of others, especially when it is a question and response measurement. So you see a patient that maybe they marry a couple might not be very free to answer some questions, measurement questions in front of the other couple, especially very sensitive questions. Language barrier, we've talked about it. Equipment functionality. If the equipment we are using is not functional or has been outdated or malfunctioning, then we are sure that the reading that we're going to get from them will also be wrong. So this will definitely impact negatively on the outcome of the measurements. The weather condition is also important. Heat waves or storms can affect the physical and mental states of both individuals, both the measurer and the measuree. So methods, techniques. So before we do anything, before we take our measurement, we have to make sure that these factors are under control, that the factors are optimal. We can never get the best condition. You can't get a condition where there are zero interferences, but we have to make sure that these interferences are under control and will not negatively impact the measurement process. Okay, let's proceed. Methods, techniques to conduct assessment and environmental analysis, especially in P&O. So there are, in order to conduct a comprehensive clinical analysis or clinical assessment, in order to identify a patient's needs and develop effective treatment plans in P&O, there are methods or techniques that are in use. Okay, so one of them is gait analysis. The gait analysis assesses how a patient will walk or how patients walk and moves, whether with a prosthesis or with an orthosis or with any mobility device. It helps to identify abnormalities, deviations, as well as functional limitations. So some of the parameters we make sure during gait analysis in P&O include step length, stride length, cadence, step width, symmetry and balance, as well as joint movements during walking, or even during stance. We also measure some gait parameters that helps us to improve in the P&O experience of the patient. Some of the tools that we use in gait analysis will include the motion capture systems for those that can afford it. We also use force plates as well. But everybody, every piano person will always use the very cheap one, affordable by everybody. And that's the visual observation. Then we have some functional mobility assessments where we are assessing a patient's ability to perform daily activities using the piano devices. So the tasks are evaluated. So it's more of question and answers where we try to understand the patient's subjective responses. How is the patient performing, okay, with these devices? How well are they not performing? What are the challenges they are having with the devices? So task evaluated may include sitting task, standing task, climbing stairs, and reaching out. So some of these tasks, we ask the question how they're performing it and some of the challenges. They give us responses. Those responses are now put in numerical forms so that we can extract numerical data for them for analysis. Some of the tools we use in functional mobility assessment include timed tests, like the timed up and go, 10 minutes, 10 meters walk test, and the rest of them. We also use functional questionnaires as well as observations. Range of motion assessment is another important method we use in conducting assessments. A range of motion evaluates the joint mobility and flexibility. For instance, when patients come for prosthesis, we try to check a range of motion across the joints of mostly the lower limb. If it's a lower limb prosthesis that we are trying to produce, we check for range of motion for at the knee. If it's transtibial, we check range of motion at the knee as well as the hip to make sure that there are also, when we discover that the patient has contractures that are affecting full range of motion like extension, hyperextension, or flexion, we can now say, okay, based on these outcomes, we can refer the patient to the physiotherapist or refer back to the surgeon to perform surgery to release the contracture. So it helps. Range of motion is very, very important. It also helps to determine if the P&O device that we have fabricated for the patient can allow for adequate joint movement. There are times we finish producing our device and we see that from the trim lines of the device, the patient can no longer perform full range of motion. So using this range of motion test, we can now determine whether is from the device. If it's from the device, we'll now formulate interventions to relieve them. Tools that we use for this include goniometer, inclinometers, and as well as the very cheap one, once again, visual assessments. Another one is socket fit assessment. This, we use it mostly in prosthetics. So here we are trying to assess the fit and comfort of the socket, which is holding the residual limb. So what are we checking here? We are checking for pressure points. We're checking for stability. We're checking for alignment of the prosthesis, especially the prosthetic socket. So one example of the tool used is this socket comfort score. We also have the four-way test where we are checking the alignment of the socket in extension, in flexion, in varus, in valgus, in AP, as well as in ML planes. And this is very, very important. It helps to check and be sure that the socket we are producing for the patient is not just going to be dumped or will not cause injury to the patient. Other type of tools used for this socket fit assessment include visual inspection as well as socket pressure analysis systems. In alignment assessments, also is used both in P&O, prosthetics and orthotics. We try to ensure proper alignment of the prosthetic and orthotic components. I've described alignment as we know it in P&O earlier to mean the the relative positioning of components to one another. So what are we saying? We're saying the alignment of the socket on the pylon, the alignment of the pylon with respect to the prosthetic foot, the alignment of the sockets to the prosthetic knee joint, the alignment of the prosthetic knee joint with respect to the foot and the etc. So we also evaluate alignment in static and dynamic conditions to know if this patient is ready to use this device efficiently. Some of the tools we use for this include the plumb lines. In fact, the plumb lines it was very popular in the days back. But now it's gradually being replaced by the laser alignment, as you can see in the picture on the right there. So you see the laser line that we use to check the alignment of the device. So with this, we can check the trochanter knee ankle alignment. With this, we can check the toe out or toe in alignment. With this, we can check the extension and flexion alignment of the prosthesis with respect to the foot and other parts of the body. In orthosis, we can also use alignment to check for plantigrade at the ankle, to check for medial rotation for patients that have medially rotated subtalar joints. We can use this to see how the orthosis corrects this alignment or not. In skin condition alignment, we monitor the skin health and integrity, whether it's prosthetic or orthotics. Therefore, we try to detect the pressure scores, skin irritation scores, sweating scores, as well as other issues that relate to the skin condition. Most times in patients that use prostheses where the stump is enclosed by the socket skin interface passes through a lot, from pressure to high temperatures to moisture and the rest of them. All these things can impact discomfort as well as skin conditions on the patient. So we use visual inspection and some other tools like the hyperhidrosis disease severity scale to estimate or to measure the skin condition, whether we are measuring pressure or we are measuring moisture, like sweat, or we are measuring temperature or skin irritation. So we may have. Residual limb volume assessment is another one also for prosthetics, where we use circumferential measurement. I think I've said this earlier, where most patients that come to us for the first time might have bulbous or cylindrical stump that need to be compressed to have an optimal socket fit. So we use our circumferential tape measurements to measure the volume fluctuations over time and record volumetric changes. Functional testings that we do in P&O will include tools like motion capturing system, gait analysis, timed up and go. I think I've mentioned this earlier. There are many of them. We have the patient feedback and satisfaction assessment. Here we involve discussing the patient experience, comfort, and overall satisfaction with the device, which will help us to identify areas for improvement. Okay, so most times we depend on the subjective feedback from the patient. Moreover, it's them that our intervention is patient-centric. So we depend on interviews, questionnaires, surveys to get this subjective feedback from them. And this can go a long way. And one of them is a socket comfort test that I have mentioned earlier. Is a feedback that the patient gives us that helps us to say, okay, our intervention today has been mostly successful. We also have sensory assessments, especially in people that have sensation issues. Okay, so it involves estimating sensory perception and detection of sensory deficits in patients. We use this most of the time in people that have neuropathies, like diabetic foot neuropathies, where they have loss of sensation, sensory loss, especially at the plantar surface of the foot. We use the monofilament vibrating fork to test for the ability of a patient to have sensation at a particular part of the body. These sensations are, as we know, are very, very important, especially when we are going to apply pressure from our devices to be sure that the patient can feel the pressure. If they cannot feel the pressure, then the load is now on us to make sure that those pressure that we're going to exert using our orthosis or prosthesis will not be too high to lead to injury on the patient that cannot know when the pressure is high or not. Okay, I think I've mentioned some of these functional outcome measures before, where we quantify the functional abilities, the quality of life of the patient in relation to their P and O use. So here we use things like prosthetic evaluation questionnaire, orthotic and prosthetic survey, and the short form 36. We also have the Trinity amputee prosthetic experience scale, TEPS, which has been reviewed recently to get functional outcome measures from the patients. So this is a tabular representation of some of the things we've talked about. So we have the four-way tests, which assesses prosthetic alignment, muscle strength testing. We know that some of these things are applied across all medical rehabilitation, but this we also use very often in PN. So we have the amputee mobility predictor that we'll talk about as an example later on. Then you have the Trinity amputation and prosthetic experience scale that I mentioned last, where it's used to assess a user experience and functional outcomes. Okay, we also have the prosthetic user profile, PUP, among others. PUP is used to assess a prosthetic user's experience and outcome in prosthetic care, while the comprehensive prosthetic rehabilitation outcomes, CPRO, evaluates comprehensive rehabilitation outcomes in patient prosthetic care. The range of motion, I think I've talked about this, the range of motion measurements we use to measure joint mobility. We have the muscle strength testing, pediatric orthotic evaluation, the OPUS I've mentioned, talked about it. All these are some of the outcome measures, which are also measurement assessment tools that we use in piano. So we'll talk about having implemented, how do we adopt or grade these assessment tools to a person, a person or a patient? Okay, so adapting clinical assessment to individual patients usually involves a thoughtful process to ensure accurate and relevant information. Here are some of the methods we use. First thing first is to understand the assessment tool. Which assessment tool am I going to use? So understand the assessment tool we want to use. Familiarize yourself with the specific assessment tool based on the table that we just saw. Know the scoring method. So you have to read the manual of this assessment tool. Understand the scoring range. What higher or lower scores indicates. If a patient records a higher total score or lower total score, what does it indicate? And what are the cutoff points for specific diagnosis or severity levels? consider the current score. Consider the current score. Can you hear me, please? Can the class hear me?
Yes, sir.
Okay, thank you. Okay, so I said consider the score, consider the patient's profile, baseline, sorry, not profile. Compare the current score today and the previous score the patient has to determine progress or change or not. Okay, so for instance, when we are managing people that have scoliosis, we use the curve angle as a measurement tool, assessment tool, to compare prognosis, to compare progress. So let's assume that on the first assessment, the patient had a curve angle of, let's say, 15 degrees. And 6 months after our Boston bracing or any other spinal bracing intervention, we are getting a curve angle of 12 degrees. Then we can say that 12 degrees is less than 15 degrees. Therefore, there is a progress. Okay, but if you got the same 15 degrees, that means that there is also a progress, because the essence of most spinal intervention, spinal orthotic intervention in scoliosis, is not to correct, but to prevent progression of the curve. So when you get the same reading, 15, 15, that means you've been able to successfully prevent progression of the curve. But when you get 20 degrees, which is 5 degrees increment, then that means that the progression worsened. The orthotic intervention was not effective. So this will help you to now make your plan on future interventions. So we have to consider the baseline. You have to follow up on these things. Then we have to evaluate in context. We have to consider the patient's medical history, the patient's current symptoms, and as well as other relevant factors. So those personal factors from the patient's perspective, gender, age, as well as other history that the patient has given you in the first contact, must be considered in the context of the assessment to be applied. Then consult clinical guidelines. Like I said, in the evidence base, there are clinical guidelines for almost all these assessment tools. You have to consult them. So refer to established guidelines or consult with a healthcare professional for guidance in interpreting the scores and making informed decisions. So there are evidence-based that helps you to say, okay, for readings from this to this is the meaning. Just like in a medical laboratory, if somebody has a blood sugar level of, let's say, 120 to 150, we say that the person has, that's the fasting blood sugar. We say that the person has a high blood sugar, or maybe the person can be pre-diabetic. Okay, so the same thing applies here. There are clinical guidelines that can help us to interpret the score. So have access to those clinical guidelines and use it to make interpretations. And based on that, make informed decisions. So I've said earlier that we have to monitor changes over time as a way of adapting this course to an individual. But that's what we're talking about at the moment. How do we adapt our scoring? Do we just measure and then we dump it? How do we adapt the scoring to an individual, to a patient? So track the scores that the patient is getting over time. And then after like a year or 2 years, you can plot a graph to study the trend or improvement or deterioration. Then use the scores to inform treatment. As we'll see later, when we try to adopt the numerical rating scale in intervention, you will see that the measurement tool can help you to inform your treatment. So adjust your treatment plan or intervention based on the patient's responses or based on the outcome and progress. Then evaluate the patient's symptoms and behavior. Scores should be considered in the context of the patient's overall clinical presentation. So as you're getting the score, correlate it with the patient's condition. Don't just use it, don't just record and measure and record for recording sake. Make sure you correlate it with the condition the patient is having. Then you can use, this is important, most times, we can use different measurement tools, just like the meter rule, the vernier caliper, the micrometer gauge can all measure the length or the width or the diameter of a device or of a unit. The same way that there are multiple assessment tools that can measure a particular parameter. So triangulate data from different tools to get a more comprehensive understanding of the patient's condition. So let's say that you want to measure the pain sensation of a patient. You can use the numerical rating scale as well as other pain measurement tools to assess the response the patient is giving you. And at the end, you can now compare all of them to have a better understanding of what the patient is having. So use multiple tools. That's why most outcome measures are not advised to be used on alone. So you see somebody using amputee mobility predictor scale, the same person will use a TEPS, the Trinity Amputee Prosthetic Experience scale. The same person will use a WHO quality of life document. What are they doing? They are trying to understand from different measurement tools the condition of the patient. Then consider the assessment tools limitation. We have to understand that these tools have their limitation. And what are some of these limitations? There are ceiling effect, there are floor effect. I said it earlier that we must understand some of these limitations so that when we are applying them, we know that yes, this is a limitation. When we get our reading, we have to understand our reading from the aspect of this limitation. We also must understand the standard error of measurement and therefore the MCID to know that beyond this, this is what we expect so that we don't make assumptions. Then we must involve the patient in the interpretation process. This is also important. Encourage patients self-report and feedback to get a more complete understanding of their experiences. We have to use technology and data analytics. We are in a modern world, the Gen Z era, so we have to use some of the tools, digital tools that are coming up for our assessment. So leverage digital tools and data analytics to track scores over time, identify patterns, inform treatment plans. Okay, in fact, the world has so digitalized that there are AIs that help in making prescriptions. We can adopt that. Moreover, there are workshops these days on the use of AI in medical rehabilitation. We can adopt those things to make our interventions more accurate. Then consult with a multidisciplinary team. Collaborate, discuss your outcomes with other healthcare professionals to gain a more comprehensive understanding of the patient's condition and develop a treatment plan. No professionals can function in isolation, whether you are the prosthetist or orthotist or physiotherapist or occupational therapist or the audiologist or speech therapist. Nobody works in isolation because it will not, you are not, if you are working in isolation, then you are so selfish that you cannot impact on the patient. The P&O person must need the physiotherapist input, must need the occupational therapist input, and other members of the medical rehabilitation. So discuss these outcome measures with others and get a better comprehensive understanding of the patient. That is why I always am a prophet that always preach on the need for medical rehabilitation to be a faculty anywhere it exists, not just being physiotherapy, but being physiotherapy, piano, everybody coming on board, because that collaboration helps us to render more functional interventions to the patient, who is the center of all that we are doing. When you have a consultation, multidisciplinary team consultation, the patient enjoys the benefit of our treatment. But when we intervene from a single perspective, the patient can never enjoy these benefits. So I use this opportunity to push this agenda to each and every one of us to be advocates for this. Discuss your outcome, your measurement outcomes, discuss it with the multidisciplinary team, get a better feedback, and implement. Continuously monitor and adjust treatments. Regularly ensure to reassess the patient using the outcome measures. So you continue to, reapply this outcome to measurement tools on the patient so that you can be able to know, is my patient improving? Is my patient not improving? What do I need to do to get this patient to be better? Okay, so we have to make sure that we do that. I've said that we have to use digital tools. I don't know why I repeated it here. So use technology to facilitate assessment and interpretation. We shouldn't shy away from technology. Some of us, I'm one of the persons that do this. Some of us enjoy our conventional, traditional methods, the manual method. But while that is good, technology has made things easier. So not just easier, more accurate. So let's adopt technology in our outcome assessments. Maintain accurate and organized records. So why this is not the platform to talk about organizing medical records for medical rehabilitation, but it's also important to keep an accurate record of your outcome, measurement outcome, assessment outcome, so that you can always make reference to their interpretations and with the scores over time. Then stay current with best practices and research. Consider cultural and individual differences when you are doing this. The way you interpret for somebody from one cultural background and the other might not be the same. So you must understand the differences. Then use assessment score to facilitate communication, share assessment scores and interpret with patients' families. So imagine that we finished assessing numerical or socket comfort score, and we maybe at the beginning, the patient gave us a score of 7/10. And then after our orthotic intervention or prosthetic intervention, the patient is giving us an outcome score of 3. This gives you a means of communicating to any person, whether it's to the patient or the family or the members of the healthcare team. So imagine coming out to say, before we started, the socket was very, very painful, but now the socket is better. That is not it doesn't give a better understanding of the experience the patient has undergone. But if you say that at the beginning, the score the patient gave us at the beginning, if you say that the score the patient gave us for the prosthetic sockets was +7 at the beginning, but at the end, after our intervention, that the score was 2, showing a +5 improvement. That gives you a better communication tool or information that you can pass to the other members of the team. Okay? You guys can still hear me, right? You can still hear me, right?
Yes, sir. We can
Okay.
hear you.
Okay, so I was having a call that would have interrupted. That's why I had to make sure. Okay, so next we are going into timing and frequency for conducting and reporting assessment relevant to P&O. So the timing and frequency, I've said earlier that we should be repeating this from time to time. The timing and frequency will depend on various factors. And some of the factors will include patient condition and needs, type of device, patient age and growth, as well as the complexity of the case. So for considering patient condition and needs, the assessments are typically performed at initial consultation, during treatment, at follow-up appointments in order to monitor the progress and treatment plans as needed. So for the first time that the amputee and the amputated person or the person in need of an orthotic device comes to us, that first time we do the first or initial assessments. Okay, then during our treatments, we do other, for instance, if the patient came for shape capture, we do the assessment at that point where we take some measurements and the rest of that. When the patient comes, as well as okay, as well as okay, sorry, I had calls that are interrupting me seriously. Okay, assessments are typically performed, we said as initial assessments, where we get information from the patient histories and the rest of them. Then during the measurement or shape capture, we get our measurements. During our fitting, we do static and dynamic alignment assessments. And then during delivery, we also perform another assessment. That assessment is now meant to make sure that there is quality control. Then we have follow-up assessment. This is based on the patient conditions and needs. Then based on the type of device, prosthetic and orthotic device will require regular checks and adjustments to ensure proper fit, function, and comfort. Then based on the age, pediatric patients will require more frequent assessments in order to accommodate growth and development. And this is very understandable considering that pediatric patients are growing rapidly. Like there are most pediatric amputated patients, especially when the growth plate is intact, are meant, and also when the amputations are done through the cortical bone, that's through the shaft, will tend to have overgrowth from time to time. So you see that you don't just give them a prosthetic device and tell them, oh yeah, go home and come back maybe the next 1 year or 2 years. No, because the child will be growing rapidly, and we expect that from time to time there might be need for stump refashioning, or there might be need for socket modification to accommodate the protruding bone. So pediatric patients need more frequent assessments then people that have neurological condition will also need, or maybe that have sensation issues, people that have insensate limbs will need frequent assessment also to be sure that the prosthetic or orthotic device is not complicating issues for them. People that have volume fluctuations, okay, will also require frequent. So it depends on the patient age, growth, and then the patient condition as well. Complexity of the case is also a cause for frequent assessment. So more complex cases, like I just said, will require more frequent assessment in order to address issues that or complications that may develop. So during the initial consultation or assessment, the comprehensive assessment is done to determine the patient needs and goals. So we have the patient's a history, medical health history is being collected, the chief complaints, and the rest of them. Then during the casting or impression, where we capture the shape of the stump or the shape of the limb. So in as much as this is done at initial consultation, it can also be done at subsequent, especially if patients are not able to meet up with the requirements for it. So this appointment is used to create a model for the device fabrication, as well as model rectification against some standards. Then we have fitting assessments, where there might be multiple fittings and assessments to ensure proper fit and function. of the device. At this time, we can perform our static and dynamic alignments. Then we have a session assessment for training and delivery. Here, assessment is performed during the training of the patient with the P&O device and also during the delivery, during quality control processes as well. Quality control processes helps to make sure that the prosthetic device doesn't have, that all the bolts and the nuts are well tightened, that the alignment is perfect as documented, that the edges and trim lines are smooth and will not injure the patient, and so on. Then we have our follow-up appointments where assessments are done on a regular appointment. It could be every 2 months, 3 months, and the rest of them to monitor the progress, address any issues, and make adjustments as needed. Then there can be annual adjustments, biannual adjustments, 6-monthly adjustments. But keep in line that this is a general outline. The specific timing and frequency depends on the individual patient and also on the factors that we've mentioned earlier. Okay, so methods of scoring standardized assessments relevant to P&O, as well as how to interpret assessment results relevant in P&O. So we'll try to go through generally some of the assessment tools, standardized assessment tools, and the method that we use to score them. Scoring standardized assessment tools in P&O depends on the specific tool being used. So the format or the process includes the following. Number one, I've said this earlier too, follow the tools manual. Every assessment tool has a manual, has a guideline. Somebody developed it. So the person specified the process of utilizing it, the process of interpreting it, and the rest of them. So each assessment tool comes with a scoring guide or manual. This provides detailed information on how to assign scores to each response and how to interpret them. Using Likert scales. Most of the tools will use Likert scales. For instance, 1 to 5 or 1 to 7 Likert scales. And these are used to measure responses, okay? Higher scores often indicate better outcomes, such as improved function or improved satisfaction or worsening satisfaction, depends on how you scored it. An example of a 4 Likert scale is shown here, where we have strongly agree being the strongest or the highest, where you have number 3, somewhat agree, number 2, somewhat disagree, and number 1, strongly disagree. So you see the flow from most negative to most positive. Then you also have an example of a 5 Likert scale, 5 showing strongly agree, 4 agree, 3 neither agree or disagree, 2 disagree, and 1 strongly disagree. If we take a look at these two, we will understand that the 5 Likert scale has tried to solve a problem with ceiling and floor effects. You see that the 4 Likert scale did not capture the population that will say, I have no response, I don't agree to anything. I don't agree, I don't disagree, I am neutral. But the 5 Likert scale now captures it. So you see that the 5 Likert scale will give us a more accurate response compared to the 4 Likert scale. And if you have a 7 Likert scale, it would have increased further the ceiling and the floor effect to capture more responses of people, not present in the lower Likert scale. Also, we can adopt, there are some or average scores. If some tools will require that after getting the individual scores of the individual questions and responses, that you sum everything up. While others will say, no, give us the mean, and we know how to calculate mean or average, okay? So make sure you follow the prescription of the manual. If the manual said sum everything, you do that. If the manual said, get the average, in other words, get the total score divided by the total number of questions, then you do that. Then some other scores will now tell you to, okay, convert your score to a standardized score. For instance, let's say that I marked a test or an exam. There are, let's say, 15 questions that I asked. And to make it easy for me, I scored each of the 15 questions one mark each. At the end, that should be 15. But this is a test, and that test should be over 30. So I am now asked, maybe I submitted 15, the 15 score points, and the head of department said, no, this is an over 30 test. Please convert the scores to 30 instead of 15 maximum. So what do? Do you now go back and give another test and then, or do you now go back and start remarking based on that? No, you simply convert. You get a way of converting from 15% or 15% to 30%. In such a way, you can now say, okay, any person that scored whatever they scored times by 2, because 15 times 2 will give you 30. That way, you have converted from your 15-point score to a standardized and accepted 30% score, standardized score. So that's exactly what we're saying. Some tools like the Opus has raw scores that must be converted to a standardized score, standardized measure called a RASC analysis for more precise interpretation. Other ones, like I think the WHO quality of life document also has this conversion requirement. So, like I said earlier, consult the manual of the assessment tool. Then third, consider MDC and MCID. Remember, I said earlier that the MDC is very closely related to reliability, while MCID is a value. Okay, MCID, minimally clinically important difference, measures responsiveness. Now, these two terms are clinically important, and they have values estimated for almost all assessment tools used in medical rehabilitation and in health. And these information are always available in evidence-based. So there are some actually that don't have, like the amputee mobility predictor doesn't have MDC and MCID, but some like the numerical rating scale has. And this helps in making decisions. It helps in making analysis to determine whether the changes or outcomes that we have observed in our patients is clinically significant or not. We'll see the adoption later. If the standardized MCID in the evidence base, for instance, is 3, and the one you have computed from your observation is 2, then you can deduce that since the observed score is below the EB, evidence-based score, the outcome is not clinically significant, in as much as you have seen that there is an improvement, but it's not clinically significant. This is very really similar and can be compared to the significances where we say is not statistically significant that we use in our researches. Then we keep on saying adopt softwares or template, adopt technology. Some tools will recommend or provide scoring software or Microsoft Excel templates that simplify the calculation, maybe whether conversion or estimation of or calculation of the total score or getting the average or the sum. And therefore, this simplifies the process for you and ensures accuracy. So always consult the templates. Now, example, I have 2 examples to provide, and I will call it a day in my presentation. So the first one I will be talking about is the amputee mobility predictor scale, and I have been introducing it all this while. Okay, so the amputee mobility predictor scale is an objective assessment tool that we use in piano to measure the functional status of lower limb amputated person, whether they are using a prosthesis or not. So the purpose and its feasibility is that it assesses functional mobility as well as predict how well an individual will be able to move after prosthetic fitting. Okay. So feasibility takes less than 10 to 15 minutes. So it's very feasible and widely used around the world. It doesn't need any equipment, just the questionnaire and then the office arrangements, like the chair, the table, for sitting, for standing, the parallel bar, the mobility device or the mobility aid, sorry. Clinicians can use it before prosthetic fitting to predict functional prosthetic mobility afterwards. We will see later that with these two, we can decide and say, okay, this amputee is a prosthetic user. Or no, this amputee is a waste of time. Forget about prosthesis, maybe get a wheelchair and the rest of it. Scoring and interpretation. It has two versions, actually. The AMP Pro, that's amputee mobility predictor scale for prosthetic users. Here, it is used for amputees that are using prosthesis. So it comprises of 21 items or questions with a total score range of 0 to 42 points. So the maximum score is expected for AMP Pro is 42 points. I will revisit this. Then we have the AMP Pro for people that are not using prosthesis, called the AMP No Pro. So it's actually for amputees without a prosthesis. Unlike the other one, it has 19 instead of 21 and has a total score of 0 to 38 points. Okay. Now, each item assesses a specific functional task related to mobility. Different, whether sitting, standing, climbing stairs, okay? So he handles and he asks questions for each of these activities. The total score is calculated by summing the scores for each item. So it doesn't look for average. It asks for total score by summing all the scores that you've gotten. A higher score would indicate better functional mobility. A lower score would therefore indicate lower functional mobility. So if the amputee, whether he's using prosthesis or not, is using an assistive device, be it walking stick, that's a walking stick, yes, or any of the mobility aids, then the person's potential total score possibilities will increase by 5 points. Let's understand this. Let's say that we are using the AMP Pro, and this person, that's the AMP Pro for somebody using prosthesis, and this person is also using a walking stick, or maybe a bilateral axillary crutches, then know that the maximum expected score for that person will increase by 5 points. So it will no longer be 42, it will now be 47. Then on the other hand, if the amputee is not using a prosthesis, but is using a mobility aid, once again, like maybe elbow crutches or bilateral axillary crutches, the person's potential total score possibility will increase by 5 points. So instead of 38 points for AMP No Pro, we now expect it to be 43. That will be the expected maximum score. Okay, so with this in mind, we proceed. So most AMP item score offers scoring choices for each response item as follows. 0 being inability to perform the task. Maybe sit, you tell the patient to stand up without holding anything, without supporting himself with the chair or with the table or with the parallel bar. And the patient is not able to perform that, then the patient has scored 0 for that entry. If the patient attempted minimal achievements or required some assistance, then it is 1. But if the patient did it completely independent with mastery of the skill, then we can assign 2. That's how the scoring is done. So some of the tasks that are expected of the patient, or some of the questions that will be asked on the patient, will include transfers, the ability of a patient to move from sitting to standing and vice versa, ambulation on level grounds, on level surfaces, ambulation with environmental barriers, endurance, step climbing, turning, etc. So the patient is expected to perform these things. If they cannot, we give them 0. If they need assistance, we give them 1. If they can perform it without any assistance, then we give them 2. So what is the clinical interpretation of this? Scores can be categorized as follows. 0 to 1 will mean poor functional mobility. 11 to 20, fair functional mobility. 21 to 30, good functional mobility. 31 to 42 of AMP Pro, or 31 to 38 of AMP No Pro will read excellent functional mobility. So from evidence-based, AMP has no MCD or MCID. Therefore, we cannot expect to get that data from the use of AMP. Now, another important application of this AMP is in the assessment of specific tasks as identified in the 5-level Medicare functional classification system, which we use to determine the prosthetic prognosis for patients. So the MFCL categorizes functional activities based on the level of amputation and the K ambulator. That's the K level. We have K level 0, K level 1, K2, K3, K4. So we have K level 0, no ability to ambulate or transfer, even with assistance. So these persons, you don't bother them with prosthesis. So you can prescribe a wheelchair for them. Then we have K level 1, can use a prosthesis for transfers or ambulation. K level 2, 3, and 4. So you see, based on each K level, based on our AMP total sum, we can now determine or classify the patients according to the K level, and thereby making our prosthetic prescription. Is this patient supposed to exceed basic ambulation skills, and is it suitable for active activities? Then it's K level 4. And we expect that the AMP outcome total sum should be between 36 to 42 for those that are not using assistive device, that's a mobility aids. Then K level 3 ambulates with variable cadence, transversing most environmental barriers. They are expected to make 29 to 35. And the same goes for K2, K1, K0. So from this, the AMP can give us an empirical data to classify patients for prosthetic or orthotic usage. Clinically, the AMP helps clinicians to predict an amputee's functional ability before and after prosthetic fitting. We have demonstrated that here. It also helps to tailor rehabilitation program based on individual needs. Based on the sum, we'll be able to predict and say, okay, this individual, we will give you this type of program. They also set realistic goals for functional improvement. Now, based on the K level that we have, we can now say, okay, this person, we expect that you achieve this level. And based on that, we must give this person the type of prosthetic component that will help him in his journey to reach that. Because when we first see a patient, we see somebody that is vulnerable, weak, but I try not to make judgments at that point based on the patient's attributes. That is why the AMP Pro, the AMP Amputee Mobility Predictor helps us to make an objective, unbiased decision. So based on that unbiased decision, we can now know what this patient can achieve in the future, and we start working from that so that the patient doesn't waste too much money. One thing about outcome measures is that when you use outcome measures efficiently, it reduces the wastage of funds on the part of the patient. So when you are able to apply the AMP and as well as other measurement assessment tools, and you come up and with a decision that this patient will perform very well on a very high activity level in the future. And you don't just waste the patient's time and money by getting low activity components at that time. You encourage the patient to spend the money that he would have spent, in many places on one thing, which is what? Components for very high activity. So by so doing, you have prevented the patient from wasting funds. So it's very, very important to set realistic goals and therefore realistic component design. Okay, the second part and the final part of this is another example. I have, I think, around less than 20 minutes, but there will be question and answers. The numerical rating scale, which also try to implement it or apply it here. Unlike AMP that doesn't have MCD and MCID, this one has, so it will help us to see this from another perspective. So the numerical rating scale is a simple, widely used tool for assessing subjective characteristics or attitudes that cannot be directly measured, most commonly pain. So the format is a question administered verbally by the clinician. It may also be structured or in a written format if you are not asking it verbally. So the instruction is that you ask the patient to rate their outcome domain, which can be pain, as a whole number on a scale from 0 to 10, 0 being no pain and 10 mean worst pain imaginable. It doesn't need any space. It doesn't need any equipment, just the pen and paper that we use to record. Time to complete is 30 seconds. So it is very, very feasible. It doesn't have any cost. So the feasibility is very high. If needed, you can take multiple scores. You can ask the patient this question maybe every 10 minutes in order to get multiple scores and then get an average, as we'll see done in the next. So psychometrics of this numerical rating scale, we have the standard error of measurement B 1.02. The MCD, you can see the MCD there. Sorry, I don't have enough time to be going through all this. Okay, then you have the MCID, the normative data not available, the ceiling and floor effect unknown. As at the time I got this, it could have been researched and included in the evidence base at the moment. It has 100% inter-rata agreements with a written NRS. Okay, case study. So we have a case study of a new patient that came for assessment. Sorry to say new patient. It's an old patient, that a prosthetic user that came for assessment. The diagnosis is that he's having a distal thumb pain during gait with her transtibial prosthesis. She reports that the pain is relatively constant during weight bearing, and during the last month has been between 3/10 at minimum and 7/10 at maximum. So you see repeating multiple scores. So during our orthotic intervention, the stump was found to have shrunk. And because of the shrinking, the stump is now reaching down inside the socket where it's not supposed to get to. So in our intervention, a prosthetic socks was prescribed and fitted. Patient was reviewed afterwards. Outcome measure employed was the NROS 11, which has a scale 0 to 10 scale. The recording results. To record OM results, standard table may be used like I used here, which has the date the patient came. Okay, so this is the other side is 2025, not 2014, please. Period is the time of assessment, the time of measurement or application of the NRS. So we have pre-intervention and then post-intervention. So for them, prescription, no prescription at the end, then, but by the post-intervention, we've prescribed and fitted a stump socks. So the NRS outcome, pre-intervention, it was 3/10 minimum during weight bearing, 7/10 maximum during weight bearing, giving us a mean of 5/10. While post-intervention, we have 1/10 minimum during weight bearing, 3/10 maximum during weight bearing, giving us a mean of 2/10. So what does this mean? So we have 5/10 pre-intervention. We have 2/10 post-intervention. So these 2/10 post-intervention will clearly represent a 60% reduction of the 5/10 average pre-intervention score. So if you check your psychometrics in the evidence base for this NRS outcome measure, this evidence-based set overall ranges are 1 to 2.17 or 15 to 38% reduction. And so any reading that will give you this is clinically significant. So from this, comparing this, you see that the 2 points we have recorded here is in the upper range of the published MCID, is within the range of the MCID values, and the 50%, 60%, sorry, not 50%, exceeds the upper range of the published percentage of the MCID. As a result of this, we can conclude that the intervention we've rendered to this patient has resulted in a clinically significant improvement. Okay, so this is a clinical application of this. So what is the use of these results? Clinical results. These results support the intervention and provide a clear reference against which any future changes in status might be compared. And for the patient, these results may help the patient to communicate his current and future experience of pain with his prosthetist. And then for audit and research, these results can be used for clinical audits, for service review, and for retrospective research. Okay, so that brings me to the end of the class. Thank you very much, everybody. Thank you, Tolulope, for having me. Back to you, Tolulope.
thank our facilitator. We are waiting for Madam Ile. But pending that time, please, if you have questions, kindly unmute yourself and ask your question.
Okay, thank you.
Miki. Kai wannan ba za ka gama ba har yanzu wani mai katon hanci tabarkalla. Su da ikon Allah inyamurai da yarba.
Questions, please.
Okay, while we are pondering on questions, I want to give the silence can mean that the workshop is well understood. So I want to give a small assignment that can be done right away and submitted now. You can give your responses within the next 2 minutes or 3 minutes while we await Mrs. Ile. So it's gonna hover around the NRS that we've just visited. So we have, just a minute, let me bring up the question. Okay, so, okay, yeah. Okay. Okay, so we have a case study. You can hear me, right? Can the house hear
Yes,
me?
sir.
Okay. Okay, thank you. So we have a patient with severe ankle arthritis was referred for orthotic intervention. She complained of pain at the left ankle with consistent intensity. NRS was used to measure her pre-orthotic intervention pain at a minimum score of 3/10 and maximum score of 7/10. And AFO, ankle foot orthosis, was fitted, and the patient was reviewed after 5 weeks. Outcome after 5 weeks was minimum 2/10, maximum 5/10. Did we get it? If you permit me, I want to share this particular screen so that this way. I will share this particular screen so that we can where is my Zoom? Okay. So I'm going to share this so that we can take a look at it and then make our expert assessment. So can we say it? Can we see it?
Yes, sir.
Okay. So like I said, we can see everything there. So
Yes.
can we have just 3 minutes to record, to interpret, and state whether this is clinically significant or not? 3 minutes or 5 minutes by 12:15, while we are waiting for Ile and your questions, we should be through. So go on. I think our answers can start coming in now. Anybody with answers can drop in the chat, or you can unmute to give your response.
This is you when you were small.
Mhm.
No, I mean when you're small, like no, that's not small. You're not small. You're big girl. Oh yeah, you're big.
Good morning, sir. Good
Yeah,
morning.
good morning. Welcome.
Okay, I am Precious Wajubiolubichuku. And
Okay.
to respond to this, based on the presentation, I think the results were supposed to be stabilized, but I'll just give a spoken or a verbal response to it. So the patient presented with severe ankle arthritis at the left ankle, and based on the results of the intervention, an AFO was used for the intervention of this ailment. And based on this intervention and the OM, the intervention that was used gave a clinically significant improvement, because we saw how that after 5 weeks, the this thing was reduced. Thank you very much, sir.
Okay, but I was expecting to hear numerical information. You are just giving me an analog statement. You are giving me a qualitative statement, not quantitative. And what we just passed through now gave us quantitative data to work with. So don't just see the patient and say, it is significant. You tried, there is an improvement. We want data, numerical data. So give me, that's why I said calculate it. So what did you calculate as your, what's the difference, MCID difference? And what is the percentage of improvement? Okay. So any other person? Okay, so
I sent a message.
Yes, I'm seeing the message in the inbox. So he said pen reduction, minimum pen reduced by 1%, by 1 point, maximum. But you saw what we did last, we got the average. So, and what is the percentage reduction? Follow what I did in the presentation we just had. Okay, let's just go straight because I don't have time again. We see that the average of pre-intervention 7 plus 3, right? Which is 10, divided by 2, you get 2 points. 1 point, you get 5 points pre-intervention. While post-intervention, we got how many? We got just a minute, let me get it.
I'm boring, yeah.
Okay, so pre-intervention, we had 3 minimum, 7 maximum.
Oh,
If
when
you
they
look
can
at-
now. Oh, when can
we have an average of 10 divided by 2, which is 5. Which is 5. Post-intervention, we have an average of 2 plus 5 over 2, that is 3.5. So when you minus that, it means that your MCID difference was 1.5. Okay? So 1.5 is your MCID difference. And that, if you check it in percentage, it will be representing 30%. Yeah, that's 30%. So with this 30%, if you go back to the evidence base, you will see that the range for clinically significance is 1 to 2.17. So 1.5 falls under there. So based on that, it's clinically significant. Based on the percentage, it said up to 36%. Sorry, 15 to 36%. And 30% also falls under there. So based on that, we can now interpret and say there was a clinically significant improvement or reduction in pain, which is almost 30% of reduction, and this is clinically significant. Okay, is that understood?
Yes, sir.
Okay, so Ms. Ile will still share the document of this presentation for further reading and study. Okay, thank you very much. I think I'll be signing out at this moment. The second presenter, I think, should be on at any time from now. So thank you once again for having me.
Thank you very much, sir. We appreciate it. She's still trying to log on. The next presenter will be coming in by 12:30.
Yes. Thank you very much. Although I've not seen any question yet, so I'll be signing out. Thank you very much.
Yeah. I think I've logged in, but I'm coming in.
Good afternoon, everyone.
Good afternoon, sir.
Good afternoon.
Good afternoon.
Right. I think we are right on time. Hello, is Mrs. Sile here?
She's having network issues. She will join, sir. You can proceed.
All right. So I actually sent her a message earlier on regarding sharing my slide. So I've actually sent her the slide. So I don't know if you are holding brief for her to help share from your hand. I will just present from here because of where I am at the moment.
Can you let me communicate with her, sir? I'll get back to you right away.
Okay, or you want me to send to you?
No, let me communicate with her. I'm using phone as well. Let me communicate with her.
Okay. I'm not sure if Dr. Anjorin said.
Is here.
Okay, Dr. Anjorin. If he's here, don't know if he can help us to do the sharing from his end while I just present from here. Dr. Anjorin, good afternoon, sir.
I've told Madam Miller to communicate with him. It's like he's online, but he's not responding.
Okay. What about, is Dr. Chikwado still here, the first presenter?
I'm not seeing his name on the list.
Okay. I don't know if Miss Blessing is here.
So maybe you should just, because of your own time frame, maybe you should just continue. I have told Madam Miller to communicate with Dr. Anjorin about the slide.
I'm actually reaching out to, if Miss Blessing Egora here.
Okay, sir. So maybe you should just start while we are looking for how to share the slide because of your own time frame.
Okay. Okay, maybe you can do this by just making anyone can share. So if you can give the access, so whoever can help from their end can do it. Can you hear me, sir?
I can hear you, sir.
So I said maybe you can authorize anyone can share so that whoever.
Anybody that volunteer to share can make the person co-host.
Okay.
Yes, sir.
Is Mr. Adebola here now?
Yes, I'm here, but I'm trying to connect on my laptop now.
All right. Good day, everyone. And as you're already aware, we are taking the presentation from occupational therapy perspective. And we've actually...
Yeah.
Hello, is anybody helping? Okay. So we're taking the occupational therapy perspective on our workshop today, which is on conducting rehabilitation assessment, the occupational therapy perspective. So the objective of, sorry, I will just pause, like there is a way we can have it projected now. So please just give me a few minutes. Sorry, can Blessing share from her end? She's already.
Yes, sir.
Okay, please. You are going to be, that's so I can give your name to the host, so you can be added as a co-host and you can help do the sharing.
I have done that already, sir.
Okay. So
You can continue with your presentation, sir, since you are still sending the slide
okay.
to everyone.
So I've just just so you can share from your hands. So proceed. So as I've said, we are looking at the occupational therapy perspective to conducting assessments in rehabilitation. So the objective of this presentation is just to make us understand the occupational therapy perspective to assessment in rehabilitation and to identify the specific areas that are peculiar to OT practice. Again, to understand the purpose of evaluation or assessment in rehabilitation and to identify the type and the sources of information that we often utilize for assessment and evaluation. In addition to that, we seek to be able to identify the steps to conducting OT-specific evaluation and understanding the scoring and the interpretation of standardized assessments or evaluation as the case may be. So my outline are these. In the course of this discourse, we're going to be looking at the introduction, what is evaluation, the potential sources of evaluation or assessment, the purpose of evaluation or assessment, and also types of information collected. In addition to that, we're going to be looking at protection measure and how the protection measure is being initiated. And again, we look at the steps that we often utilize to conducting evaluation or assessment in occupational therapy, the timing and the frequency. Also, we look at some specific standardized assessment. In addition to that, we look at the scoring and the interpretation. And the last but not the least, we look at how these evaluation or assessment is being or are being documented or interpreted. So, as a way of bringing us into the introduction, I'm sure must have now appreciated or understood the fact that we are looking at this presentation collaboratively. That is, we are looking at how assessment is being done as rehabilitation professionals. And we know that rehabilitation, as it is being practiced globally and even in Nigeria, is usually multidisciplinary. And that underscores the structure of this presentation, making it to be multidisciplinary and with each profession coming up with their specific or their peculiar perspective to assessment. Now, but it will be very important for us to understand what we mean when we talk about rehabilitation. What exactly are we talking about when we mention the word rehabilitation? So basically, rehabilitation is a set of intervention that is designed to optimize function and reduce disability in individuals with health conditions in the interaction with the environment. Now, we can spend so much time trying to unpack this definition because there are salient points that calls for special attention if we must understand the whole essence of rehabilitation, evaluation, or assessment as the case may be. Number one, it's a set of intervention, meaning that it is not just a singular intervention that makes up what we refer to as rehabilitation. And again, the overall goal is what is to optimize function. So the next goal of what we do in rehabilitation, and particularly or more in peculiar terms in occupational therapy, is geared towards optimizing function and reducing disability. And again, this disability has always been impacted by the environment, either the physical environment or the social environment. So that is why what we are going to be looking at in our assessment or our evaluation, as the case may be, we definitely have a lot of concentration or focus on the environment. So it is important for us to understand that comprehensive and effective evaluation is key to a successful rehabilitation. And rehabilitation evaluation or assessment refers to systematic process that healthcare professionals use to evaluate various aspects of clients' physical, cognitive, or emotional or functional status in order to develop an intervention plan. So what we are looking at today is what we do as professional rehabilitation professionals to ameliorate or address problems that are physical in nature, cognitive in nature, or psychosocial in nature. And this is to help us to be able to come up with a treatment plan that will help us to improve the condition of the patient. Please, Ms. Adibola, are you through with, are you able to share now? All right, we'll move on. So now you observe that I've been mentioning assessment and evaluation interchangeably. Assessment or evaluation interchangeably. And the reason for this is not far-fetched. Ideally, in the context of occupational therapy, what we are looking at today is actually referred and regarded as evaluation. Evaluation, not assessment. So we are looking at the OT perspective. Now we are the subtitle of OT perspective to assessment. And what is the OT perspective? The OT perspective starts with understanding what exactly we are looking at, which is what evaluation. So all what we are discussing today can the general term or the broad terminology for it is actually evaluation. And why do we say that? Because the reason is that evaluation is actually the overall process that is concerned about gathering information about a particular patient condition in order to be able to develop a treatment plan. And this process can take different techniques or different approaches. One of them is actually assessment. So as I said before, the perspective of occupational therapy is that what we are referring to as assessment is actually called evaluation, because in evaluation, there is what? assessment, and other techniques that we can use to gather information about patient's condition. So evaluation is central to occupational therapy because the outcome of other processes likely depend on it. Evaluation may be once and for all, or it can be what a continuous or a sequential endeavor towards a patient or a service user. So an accurate evaluation can determine the effectiveness of the OT intervention. Dr. Chikwado. Hello, sir. Hello.
We are with you, sir.
Yes,
Sir?
Dr. I was actually expecting a response from Dr. Chikwado.
He has joined.
Okay, yes. So I just want to, please, I can send you the message, the slide, so you can help us to, okay, like Blessing is helping to share already. Yes, thank you. Right, so we are on slide number 6 now. Can you just scroll to number 6, slide number 6? Thank you, Blessing. Yes, and put it in projection mode. Thank you. Right, so I've established that fact that what we are referring to today is actually evaluation, because evaluation is like what the universal said, which has a subset of assessment, and there are other subsets that we are going to unpack as we proceed with our presentation. So still talking about evaluation. So I'm going to be using the word evaluation. And as I said before, this speaks peculiarity of the perspective of occupational therapy on the discourse. So evaluation refers to an overall process of information gathering, interpreting data needed to plan intervention, including developing an evaluation plan, intervention plan. And it's all about what? Collecting data, interpreting data, and documenting them. Evaluation is a more complex process that includes interview, observation, and the use of testing and assessment. So we now see where assessment is posited in the bigger context of evaluation. So evaluation and treatment should always begin with a comprehensive occupational profile. So this is one of the peculiarities to OT perspectives to evaluation. So it should begin with what? Occupational profile. And what occupational profile is all about, we're going to see as we proceed. Okay, so next slide, slide number 8 now. Evaluation is carried out by an occupational therapist. Now, in the profession of occupational therapy, globally, there are 2 cadres of professionals that are recognized. On the one hand, there is the occupational therapist, and we have the occupational therapy, certified occupational therapy assistant. So in a situation or in a context where you have the occupational therapist working with the occupational therapy assistant, it is expected that the occupational therapist will be the one to engage in the comprehensive assessment of the patient, although these can be supported by the certified occupational therapy assistant. So, but this is just trying to establish the relationship of OT and OTA in a situation whereby 2 of the professionals work in the same setting. So evaluation, just like every other OT process, should be with valid consent. This is very important. You know, oftentimes in our own practice context, particularly in Nigeria, we often overlook the concept, this concept of consent. We just feel that, oh, because this patient has got needs, and here we are, the professional, we've got the right to actually administer our intervention. No, in a standard clinical practice, the consent of the patient is very, very important, because there is something that is called patient bill of right. And one of their rights is what? They have the right to refuse treatment, and they've got also the right to determine who sees them part time. For instance, some of us, for some patients, for some religious reason, they may have a kind of a gender preference. Maybe you are there in the corner and you need to see a woman that has a maybe burns injury, and you need to do a kind of scar massage or for the patient, or you need to do a kind of dressing assessment or retraining for a patient that has had this kind of problem. And you are as an occupational therapist, a male, the patient has the right to say, oh, I don't want to be seen by the female patient can say, I don't want to be seen by a male therapist. So these are still within the purview of the right or the consent of the patient, which we have to continue to get. And one thing about consent is that it is ongoing. Okay, that you got consent today at the beginning of the assessment, when you have to do continuous assessment or you have to re-engage the patient, that shouldn't make you to assume. You have to keep getting the consent, and the consent has to be documented in case of future breach of contract or litigation. So broadly speaking, there are three types of evaluation that we reckon with in occupational therapy. We have what is referred to as what? Initial evaluation, continuous evaluation, and discharge evaluation. Next slide, please. Slide number 9. So I'm sure the first speaker, Dr. Chikwado, must, I think, because, as much as we have a particular perspective to evaluation or what our colleagues refer to as assessment, okay? We have, as much as we have a peculiar perspective, there are still some ground of commonality. And I think this is where what I'll be sharing now resonate with the perspective of my other colleagues from other professional bodies. So number one thing, specifically in OT, which I believe applies to other professionals as well, the purpose of evaluation will be to establish therapeutic rapport. And as clinicians, we understand the importance of this, because the friendly and the welcoming atmosphere that you are able to create at the beginning of your engagement with your patient will go a long way to determine how cooperative they are going to be with you and how they oblige you to carry out your intervention. So it is very, very important that preceding every other engagement, there should be a kind of an intentional and a purposeful attempt to establish rapport with the patient, and evaluation affords us this opportunity. Also, it establishes patient identity, in the course of your interacting with the patient at the level of evaluation. You are able to identify the peculiarity or the identities of this patient. Again, you obtain information through it, understand the patient past and current health status. It helps us also to identify the pre-existing condition or risk factor that may affect your rehabilitation. There are some patients that may have some kind of premorbid health challenges or some pre-admission. Although in other contexts, they refer to it as premorbid because they always consider the present admission or the reason why the patient is being admitted as the morbid condition of the patient. So they will refer to any other problem the patient presents with as premorbid. So you may be looking at maybe the personality, the personality of this individual. For instance, a patient you are going to engage in therapy, or you are going to do assessment, and this patient has got a kind of a schizoid personality or a paranoid personality. So such a patient may begin to bring up some kind of behavioral display in your engagement, which may kind of impact on the therapy-patient relationship. So assessment makes you, or evaluation makes you to understand the details of all this. And again, it's an opportunity for us to educate and reassure our patient on their condition, establish diagnosis in relation to functional limitation. Now, as occupational therapy, as I said, I've been issued that we are always concerned about functional recovery of our patient. For instance, when a patient has a kind of impairment, for instance, maybe either pain or restricted range of joint motion or poor muscle strength of a particular group of muscles, fine, as much as that is of interest to us, but what is more concerned, it's of interest to us is how does this impact on the patient's ability to carry out his activities of daily living. For instance, the patient has complained, I have restricted shoulder flexion range. Now, that will make more meaning to us as occupational therapists if this limitation has impacted the patient's ability to don his garment, okay? So that's why we are always concerned about the functional implication of the impairment or the disability that the patient is going through. So evaluation affords us that opportunity. Again, it helps us to determine the client functional potential. So it is the course of relating with this patient during assessment or evaluation that you are able to project that, this patient is likely going to end up with this kind of prognosis. For instance, you are seeing a patient that has high-level spinal cord injury, let's say C4 complete spinal cord injury. that you know that all the muscles below the neck region, they are paralyzed. So that kind of patient, right from the time of your initial assessment, you're able to say, oh, this is likely to be the prognosis that the patient will end up with, and can help you to begin to evolve plan on how to manage the patient even after your treatment regimen is over. Again, it helps us to identify barriers to rehabilitation. So there are some, when we say barriers to rehabilitation, there are some kind of dynamics that can impact our patient rehabilitation. It can be the family dynamics, it can be the kind of actual, the social environment of the patient, the physical environment in terms of home environment, architectural barrier that can impact. So your detailed evaluation can give you this understanding and give you the understanding and help you to have insight on how to plan towards managing them. And the last but not the least, we can, through their detailed evaluation, we're able to have kind of outcome measure, that is, we're able to state, to measure more objectively how the patient has responded to our treatment plan. Now, the sources of information, which I believe Dr. Chikwad must have spoken about as well. So sources of our information can be from referral note, the medical record, the patient interview, which is the primary source, okay? And family members' reports, which are like what is being referred to as collateral information, again, or subjective information, previous rehabilitation record. There are some patients that may be presenting, for instance, a patient that had a kind of an acute stroke. It's possible that that patient must have had kind of chronic condition before that will have warranted intervention from rehabilitation. So looking at, this past record can give insight into that history of the patient. And again, another source of information can be MDT members, can be from the physiotherapist, occupational therapist in another setting or in the previous setting where the patient has been seen, or the PNO or the doctors, nurses. So any members of the multidisciplinary team can be a source of information, and outcome measure reported by the patient, maybe in their previous experience, can also be a source of information for evaluation. Now, where do we assess or where do we evaluate? So I will use the word evaluation because, as I said before, in the course of evaluation, you may be measuring, you may be testing, you may be assessing. So which are like subcomponents of the overall information gathering process. So assessment, evaluation, or assessment, as we want to call it, can take place in the OT clinic, in the hospital, in the home of the patient, in the workplace, in the community, and even in school. For instance, you are dealing with a patient that has sensory processing disorder, or maybe a patient that is on the spectrum, autism spectrum, and you want to look at, and this patient is attending school. So because there will be some kind of behavioral display or communication presentation that this patient may not be able to present at that limited time they are spending in your clinic. So you may need to observe the patient in the school, in the natural community, to see how the patient engages with other children in their play. Typical of a child with autism is that, they have a kind of this artistic thinking, trying to do things on their own, being isolated and not engaging, not communicating. So seeing them in groups, in community, in schools can make you to have a deeper insight on the severity of their presentation. So that underscores why our assessments are not just limited to the clinic. Again, what are the basic requirements that we need to put in focus when we are conducting our evaluation? Number one thing, we need to understand the knowledge of current standard practice. Knowledge is ever dynamic. Practice regulation, standard operating procedure, treatment protocols, they are always evolving, okay? And we need to be at par with the current standard of practice. Some intervention that must have been adjudged to be like the best standard of practice 10 years ago may not be relevant at this point in time. And I think that underscores why we are even having these workshops, so that we can upskill ourselves and be acquainted with the best current trend of practice. So that is very germane to a very fruitful and very effective evaluation. So knowledge of current standard of practice, knowledge of the patient operational profile. That is, what is the living environment of the patient? What is the operational status of the patient? What are the issues that we refer to in the OT context, client factor, that are actually very that are impacted the patient. So again, we need to have a good, the availability of the standardized assessment. Sometimes you want to do some objective assessment or evaluation, but the instrument we want to use may have to be bought. You have to pay some hard currency for it, and that in a way can affect the objectivity of our evaluation. Again, the local context. So oftentimes we resort into what? Improvisation, but oftentimes when you have to adapt a standardized assessment into a local context, the psychometric property of it must have been tampered with, but sometimes we are constrained that we just have to make do with that. So that is one of the major considerations that we need to pay attention to. And in addition to this, we also consider the requirement, we also consider a knowledge of the assessment tool, that is the psychometric property. When we talk about psychometric property, I will delve more in detail into that, but we're looking at how effective is the instrument in measuring what you want to measure. So it speaks to 3 specific parameters such as validity, reliability, and responsiveness, which we're going to be talking about or we will unpack in subsequent slides. So another requirement is the impact of the assessment result on the client's functional state. So there are some assessment procedure that we need to that may impact even the functional state of the patient. For instance, a patient that is having COPD, okay, and this patient, they will be likely to have breathlessness, easy fatigability, and you want to exhaust your assessment in one session, that may be counterproductive. So, and the patient may not be able to have their activity tolerance or the energy level to be able to withstand that. So you need to understand what is going to be the impact of a particular assessment that you need to engage per time, and for you to make adequate and the appropriate clinical decision as per when to engage what assessment. So that brings me to slide number 12. Blessing, thank you. Now, what are the types of information that we gather in evaluation as far as OT is concerned? I think also for those that were part of Dr. Chikwado's presentation, I think I talked about some of the things that are already outlined there, demographic information, which I'm not going to unduly belabor, the social history, the past medical history, the functional limitation and disability of the patient, the diagnostic test results. Now you want to look at what is the findings from the CT scan, the MRI. You want to look at what is the findings from the chest X-ray or whatsoever X-ray the patient must have had, maybe as an orthopedic case, the physical examination findings, and more importantly, as occupational therapy, you are looking at also we are more interested in the occupational profile, which speaks to the summary of the client's occupational history and experience as described by the patient. And it includes the client's pattern of living, interests, values, and need to relate to the current situation. Now, why is the occupational profile very important? It is important is that it can go a long way to actually inform our treatment modality. People relate with what they are used to easily. For instance, if a patient has had, for instance, a patient that has both bone fracture, tibia and fibula of the lower extremities, and this patient is being referred to us to rehabilitate this patient, and this patient primorbidly was a tailor, and this patient at the rehabilitative phase of their management being referred to occupational therapy. So if this kind of a patient is being introduced to like sewing activity, like having to sit on a machine, sewing a piece of cloth and using the leg to pedal, to manipulate the pedal of the machine, that will make more sense to that patient. And the patient is likely to engage more because it resonates with the occupational profile, the premorbid occupational profile of the patient. And the patient attention is being drawn to the piece of cloth being sewn. At the same time, the muscle atrophy or the weakness or the restricted range of motion that must have set in as a result of immobilization in order to ensure that there is union between the fractured bone. As all those musculoskeletal issues that must have arisen can be addressed as the patient is manipulating the pedal of the machine. And that patient is likely to find more meaning in that kind of activity than something that is completely different from what he can relate with. So what I'm trying to say in essence is that having a good understanding of the occupational profile of the patient can inform our treatment modality and the choice of activity that we engage patients in. So now, there is something that is very important to our perspective, to assessment or evaluation, and that brings us into the concept of what we refer to as OT domain, which summarizes the key areas of OT evaluation. And we are going to be looking at that in a few slides from now. But before we go into unpacking that in detail, what are the factors that inform or that affect our evaluation as occupational therapists? What are the factors that impact our evaluation? Number one, we have the personal factors, we have the environmental factor, and we have the clinicians or the raters factor, that is the one that is engaging in that assessment. What are the factors that are peculiar to him that can impact on the objectivity of or the reliability or even the validity of the assessment that is being carried out? So looking at the personal factor, which actually is broken down into two, there is a component of which relates to the physical factor, and there is a mental factor. That is, what are the issues that are going on with the that are going on in the realm of the physical component that can affect this. Number one, the fatigue level of the patient. For instance, I just gave you an example: a patient that is having a COPD, or a patient that is having a kind of maybe multiple sclerosis. Okay, as a result of the uh, the problem that this patient are going to present with respect to their level of activity tolerance, their level of or a COPD patient may be having breathlessness. That kind of patient will may find it difficult to be able to see through to go through 1 hour or 45 minutes of assessment, and their active participation in the assessment procedure evaluation may also be affected because of their level of tiredness. So that is one of the ways physical factor can impact or can affect the evaluation. What about substance use? Patients that are, this actually happen more maybe when we are engaging patients that are having psychosocial challenges. So medication, there are some kind of medication that have side effects, like some kind of antipsychotic drug that will leave, or antidepressant medication that will leave the patient with either tremor, or that will make them to become drowsy, that will make them to become having low attention span. And this can actually affect their level of engagement in the evaluation, and resultantly affect the outcome of the evaluation. So hunger, altered cognition, for instance, a patient that is having delirium, maybe as a result of a long stay in hospital, or as a result of acute infection, maybe UTI or sepsis of any kind, and of any nature that the patient must have even acquired maybe while on admission. And the patient level of alertness or cognition, orientation to its environment, time, place, and person can be affected. So all these can, in a way, mask or affect the quality or the outcome of your evaluation. Again, impaired gross or fine motor skills. There are some, condition, maybe a patient that has cerebral palsy, a patient that has Guillain-Barré syndrome, a patient that has a stroke. All these will have direct impact on their gross and motor, fine motor skill, which can in a way affect the evaluation. Again, chronic or acute medical condition, and patient severely slow psychomotor speed, maybe patient, even not even a physical patient that have maybe depression. Some of them could have a kind of psychomotor retardation that can affect your assessment or your evaluation in the long run. Severely impaired language function, those that are dysarthric, maybe secondary to stroke, all these can play out to affect your evaluation. In addition to this, the mental factor, we see history of trauma, a significant agitation, intellectual disability, cognitive impairment, social maybe problem with ability to follow instruction, attention span, ability to recall, to retain information, significant impulsivity. We may see this more evident in a patient that is having maybe pediatric patient, a patient that is having attention hyperactive disorder, or even patients that are manic, patients that are having mania. You see them, they have this impulsive, significant impulsivity and severe impaired attention, alcohol use, and the likes that we can see on the screen. Slide 13, please. 14. So again, there are many environmental factors that can impact or affect our assessment, which include accessibility, the caregiver concern, the family influence or family dynamics, living situation, availability of appropriate corrective devices, accommodation. For instance, a patient that that cannot ambulate independently, and this patient, because he needs a kind of wider base of support on ambulation, and this patient, instead of using frame for functional mobility, you've given this kind of patient walking stick. That in a way can affect your evaluation, or patients that have environmental concerns like poor lighting, ventilation, temperature, and maybe there's a lot of distraction where the assessment is going on. That can in a way affect the outcome of our evaluation. Now, in occupational therapy, we have many models and framework that tend to influence our perspective, that shape our perspective to assessment. These models, they've been engaged, and they have reliability, they have validity, and they are quite responsive in when we engage them to shape our understanding, our perspective to assessment of our client. So one of these is the model of human occupation, which focuses on how motivation, routine, and performance and environment influence human action. That is the personal factor of the patient. How does he interact with the environment to determine how the individual engage in occupation, which is our hallmark for rehabilitation as far as occupational therapy is concerned. We have the Canadian Occupational Performance Measure, which speaks to a client-centered tool that helps individuals to identify and prioritize everyday activities of daily living, everyday issues that restrict their participation. Again, we have the Person Environment Occupation Performance Model, and we have the OTPF. Now, and in addition to this, we have ecology, human performance. Now, putting all these together, there is a common denominator to all these approaches or framework. What is the common denominator? These approaches, what they advocate for is for occupational therapy to have a very holistic perspective to patient evaluation. What do I mean by that? We are not just treating the impairment. We are not just looking at the performance component like this. Oh, this patient has poor muscle strength. This patient has restricted rate of joint motion. This patient has breathlessness. This patient has tightness of the hip adductor. We are not just looking at that. We are looking at how does this actually impact the occupational performance of this patient, and in relation to the human environment and the physical environment. So, and one of the approaches or framework that beautifully explain this is the OTPA, and that brings me into the next presentation, which is on slide 16. Listen, slide 16, please. Right. So OTPF is actually a word that stands for Occupational Therapy Practice Framework. Occupational Therapy Practice Framework. What is Occupational Therapy Practice Framework? This framework actually evolved from the careful attempt or intentional attempt to ensure there is a level of uniformity in OT practice, irrespective of the content and irrespective of where who the therapy is. So it was developed by American Occupational Therapy Association, and the framework is actually divided into two sections broadly: the domain and the process. The domain actually outlines the profession's purview, that is our perspective and areas that we focus on when we are looking at any disabling condition, while the process speaks to the practitioner, the step-by-step procedure that we engage while we attempt to intervene in a patient condition. So the occupational therapy practice framework is an ever-evolving official document. So from time to time, like the space of interval of 5 years, is being reviewed. So that it's always updated so that it's in keeping with the best practice, that is, the best practice per time, okay, standard of practice per time. So the framework is divided into what I've said before, the domain and the process, okay? So the occupational therapists use this framework because we are skilled in evaluating all aspects of the domain, okay? And what are these domains? We're going to look at them. We're going to look at them in detail. So coming back to slide 16. Now, slide 16, what are the domains? We're looking at the domain speaks to what are the areas that we focus on. We are looking at the activity demand, or starting with from the basic performance component, which is also known as performance skills. Performance areas of human occupation, or what we call performance areas. There's what we call performance patterns. There's another domain of the performance context. There is a domain of activity demand, and there's the domain of client factor. All these 6 blocks make up what we look at. So each time we are doing our evaluation, we are looking at how does the impairment that the patient has presented with impact the performance area. For instance, the patient has had stroke. What are the problems that are quite visible that may interest occupational therapy? You'll be dealing with problem of what? Abnormal muscle tone. You'll be dealing with problem of what? Reduced range of motion, depending on the stage which the patient is being presented, if stiffness had actually set in, or you're having kind of flexion synergy in upper extremities or lower extremities that is limiting the voluntary range or the full range at different joints. So you'll be dealing with problem of what? Joint stiffness or reduced range of motion. You'll be dealing with the problem of what? Reduced muscle strength. And you may be dealing with problem of what? Problem of impaired sensation, depending on the underlying pathology, which particular part of the brain has the impact, okay? You may be dealing with the problem of cognition, vis-a-vis the memory of the patient, the reasoning of the patient, the judgment of the patient, the ability to follow instruction, the attention span, the patient's sense of patient visual spatial function. All these that I've talked about, they are within the domain of the performance component. The performance component speaks to the essential skills that an individual needs to engage in the performance area, which is also known as areas of human occupation. And what are these areas of human occupation? Everything we do on daily basis, okay, can be clustered into the subcategories of these areas of occupation, vis-a-vis your self-care, your leisure and play, your work and productivity, depending on your profile or your occupational identity. So for everything we do on daily basis, under this area of human occupation, performance area. Now, with our constant interaction, using our performance skill to engage in the performance areas, we build hobby, we build routines, we build roles. Okay, hobby habits. What are the habits? Those are those things that we do from time to time that are peculiar to us. So the gamut of all our kind of consistent pattern activities leads to our routine, and these make us to fulfill our role. For instance, somebody that is like housewife, the role of that individual will be to what? You are a mother to your children, wife to your husband, you are home manager, and a lot of roles. But that individual, what makes the person to be able to fulfill those roles is the ability to do what? To prepare me for the children, to do what? To bathe the children, to attend, maybe to do the laundry for the family, for the husband. So all those activities built into the daily routine and helps her to fulfill her role. So we look at how the underlying deficit has affected the performance of all those routines and the roles fulfillment. And again, we look at the activity demand. Each time we want to remediate or intervene in any condition, we look at what are the demands for each activity. Now, what do we mean by this? If you are, for instance, I gave an example of a patient that had a kind of maybe peroneal nerve injury or that had a tibia and fibular fracture, and at the rehabilitative phase, the patient is to be seen by occupational therapy. That's activity of sewing a piece of cloth has space demand for that activity to take place. It has time demand. There should be time definition for that task to be completed. It has what? It has cognitive demand because the patient should be able to follow instruction on how to thread the needle, on how to what? To pedal the machine, has a kind of it has kind of musculoskeletal demand. The patient should be able to do to maintain normal postural alignment in sitting. The patient should be able to have normal sitting tolerance. The patient should be able to have normal anterior weight shift and posterior weight shift. Because by the time you want to lean towards the machine to thread it, to go back and forth, you must have a kind of voluntary control of lower extremities and upper extremities. These are the musculoskeletal components that are required for that activity. So each activity we engage in occupational therapy have their activity demand. What about client factor? Client factor actually refers to the disability status of the patient. You know, there are some patients that they are already living with some level of deficit prior to your time of engaging them, and that will definitely impact how they engage in the activity you are giving them. Again, the social environment, are they living alone? Are they married? Are they kind of having children? All these can impact what we do. And this cultural environment, what is their cultural interpretation to your intervention? So all these has a lot of implication on our intervention and our evaluation. Also have to give credence to that. What about the physical environment in terms of accessibility, architectural barrier? What is the height of the bed? What is the height of the toilet? What is the height? What is does the patient have to navigate steps in access to their property? Does the patient have to, is the patient living in a story building that needs to manage steps? All these have to be factored into our evaluation. So you could see that a detailed and a good understanding of occupational therapy practice framework actually helps us to be able to be very holistic and comprehensive in our evaluation. So I advocate once again that every occupational therapy professional should have a good understanding of this practice framework, because if you look at it, if you look at more, you look at it that it also seems to be subsumed in this approach. If you look at the COPM, there's a component of OTPF that is also reflected there. When you look at the other models, okay, you see that they are actually containing this. So it's very important. I'm talking about the process. The process, broadly speaking, speaks to what the evaluation, intervention, and outcome. So broadly speaking, our intervention as occupational therapy is summarized in terms of the process in all this. One of them is what we're trying to unpack this afternoon to see how they relate and connect with other processes. So I think enough of remedial studies on teaching on OTPF. So now can we go to slide let's go to slide number 19. Slide number 19. So coming back to our discourse on evaluation now, you know, when we talk about evaluation, you know, it's often said that when we fail to plan, automatically we fail to do it. We plan to fail. So if our evaluation ab initio is not well thought out, we don't have some level of intentionality in terms of preparing, making some essential preparation, it's not going to fulfill the objective. So that brings us to the next slide, slide number 19, preparing for evaluation. Now, when we have to prepare for evaluation, what are the things that we need to look at? We need to think about how do we prepare our patient, how do we prepare our environment and the activity, I beg your pardon, and how do you prepare, environment, the client, and yourself. So in preparing yourself, what are the things that are very essential? Slide 20, please. Now, in preparing yourself, you need to decide what type of assessment do you want to engage? What type of interview do you want to engage? Are you going to do a kind of standardized assessment, or what you are going to do first, you engage interview And after you have built rapport with the patient and looking at the activity tolerance, the level of cognition of the patient, okay, you will then do what? Proceed to use some standardized assessment. Okay, but we need to understand that our assessment as occupational therapists usually start from, now this brings me back to the concept of the process, OT process. Our assessment or evaluation starts from screening. And what do we mean by screening? Screening is just the quick check that you are running on your patient or your service user to determine the eligibility of that patient for your intervention. You know, sometimes there's since we operate MDT approach to patient management, there could be sometimes that a patient may be referred to you at a point in time that the patient may not require your intervention. So a quick check, and what are the things you are looking at? What are this patient presented with? Is the patient having any kind of performance component deficit? Is there any impairment? Is there any disability? Is there any occupational performance deficit that will indicate occupational therapy intervention? So that quick check you are running is referred to as screening. It's after that you proceed to the specific assessment you want to engage, either interview, observation, testing, or measurement. Now, that speaks to the preparing of oneself. So you need to determine what type of question you want to ask a patient. Is it going to be open-ended question or closed-ended question? If you want patient to be more expressive, you need to ask your structure of question in a way that will make the patient to want to explain, not a question that will definitely determine the what that will definitely stimulate an automatic response or a yes or no answer. And this becomes very interesting when you are dealing with a patient that is that is dysarthric, okay, or that is having problem of aphasia that have challenge with expression. So you need to determine what question, because if questions are not well structured, it can be more confusing or more challenging for the patient. So you need to determine the need of the patient to structure your question. Again, determine the timing. What is the right timing? What is the duration you want the assessment to last? Or there are some patients as a result of their pathology that, they have this kind of early morning stiffness, or the best time to see them is in the morning, because as the day progresses, they have they begin to have reduced activity tolerance, their attention span begin to dwindle. So you need to determine the right time depending on the need of the patient to engage your patient. And for instance, you are dealing with a patient that is having dementia. There's this concept that is referred to as sundowning. That is, all the cognitive challenges the patient have, becoming apprehensive and becoming agitated. They have more presentation when it's getting towards evening period. So you know that your assessment has to be very early in the morning when the patient is still at their bed. So that speaks to timing, and that is part of the preparation one has to do for oneself as the therapist. Again, for the client, the patient have to be what? You need to review the referral cards. That gives you some preliminary information and helps you to prepare the patient to know what condition you are dealing with, or what are the demographic information that you need to bring to bear in determining the right assessment or evaluation technique you are going to engage. You describe your role and obtain consent, and again, preparing the environment, choose a private and a quiet place with good ventilation, less distraction, and with that, you'll be able to do a very meaningful assessment. Now, steps to evaluating occupational based on OT perspective, we identify the overall purpose of the evaluation. Number one thing, you have to determine what is the purpose, what you want to achieve with it. You have to identify the client needs, because assessment is usually need driven. Okay, you explore the client's relevant activities so that the activities that are what you are going to be using maybe for your assessment or for your intervention can be the one they can relate with. Estimate the client factors, okay, which I've spoken much about when I was talking about OTPF. You have to identify the contextual features that affect assessment. What are the contextual features? Are there kind of social issues, social context issue, okay, or physical context issue that can impact that? Consider your features of assessment, the features of the assessment tools you are looking at. How sensitive are they, or what are the peculiarity of that assessment you have chosen? Now, having said this, there is a quick case study that I want us to engage in, so we can actually bring to bear all what we have learned so far. So case study, case study, case study. And I want this to be interactive, especially for my OT practitioner in the house. And it's not limited to the OT practitioner because I'm sure what we've looked into, everybody in the real profession can relate with this. Now, our case study on evaluation in the context of OT is this. So here I present Ms. J, who is a 55-year-old married woman and a mother of 3 children. She lives with her children and her husband. Ms. J was diagnosed with cerebrovascular accident 6 months ago. Her current impairments include sensory, motor deficit, cognitive challenges, and mild depression, all of which have remained unresolved. Prior to the onset of this CVA, Ms. J was an active individual in terms of occupational profile. Okay, engaged in several meaningful occupations, including working as a school teacher, managing her household tasks, engaging in daily prayer 5 times a day as a Muslim, and attending evening journal classes, and which is her own preferred leisure activity. Okay, following her CVA, she has experienced difficulty in resuming all these valued roles. So using OTPF, identify focus of occupational therapy evaluation in Mrs. J. So this is what I want us to do together, and I will really appreciate if I can have responses. So using OTPF, and just a quick reminder, OTPF was the framework that talks about the domain, what we look at in our patient, and the process aspect of it. So using OTPF, what are the things that occupational therapy evaluation will be looking at? Can we have responses, please? Can we have responses, please? Anyone that wants to volunteer to integrate OTPF into these? All right, okay. Without wasting much of our time, looking at that case study, you see every domain in this woman is being implicated, okay? As you can see, we are going to, in terms of the performance skill, which is also known as the performance component, this woman is going to be having issues with what? Coordination, coordination of our muscles. There's going to be likely going to be what? Reduced muscle strength, processing skill of this woman, okay, which involves like the planning, the sequencing, the organization skill of this patient can be affected. And the fact that this patient is now living with some level of disability is going to limit our social interaction. So social skill and interaction is also affected. So now coming to the performance pattern, the roles are as a teacher, caregiver, as a worshiper, because we're told that she prays 5 times in a day. Is going to be affected. She's not likely to be able to assume the normal posture. You know how the Muslim sisters, how they pray. She's not likely to be able to coordinate her body, her muscles to assume that sitting position or leaning position to be able to engage her prayer, even to, and her fine motor coordination also can be affected, that she may not be able to do her ablution. So these are the ways occupational therapy we look at this patient with respect to the performance care, the performance patterns, and the routine are religious routine, family routines, like she's likely going to be a homemaker, home manager, the wife, mother, and all that. So she may not be able to function in those capacities. And again, what are the activities that may be affected? All our activities of daily living, both the basic activities of daily living, like bathing, dressing, toileting, instrumental activities of daily living, shopping, meal preparation, going to the mosque to pray, and all our religious activities will be affected. Again, she may not be able to return to work, and our work readiness is going to be affected. Leisure, we're reminded that she attends a journal class, so she may not be able to attend this, and community interaction and integration will be a problem. And still using the lens of OTPF, looking at the client factor, our body function, body structure, belief, and spirituality is going to be affected because, it is like a routine, or what do we call it's like one of the pillars of the Islamic faith for them to engage in 5 times prayer in a day. So you could see our belief and our spirituality can be affected. So that is under client factor. Now, talking about context and the environment. So it's possible that this patient may be struggling with inaccessible bathroom. You imagine if this patient had a bath that she needs to step into before she has her bath. So that's her inability to coordinate the movement to manage stairs is going to limit this. Or if she has to navigate stairs, maybe from the access to her house, that's going to be a problem. Again, if her condition is so serious that she has to use wheelchair and she lives in a story building, or she needs to access the stairs, you will not be able to use wheelchair. So social environment, cultural environment, and the temporal. So temporal actually speak to the stage of which the condition is. So that can be affected. And in our own case, our case has actually lasted for about 6 months. And in terms of the virtual context, which is still part of the context and environment, we see that she may now be compelled to switch to shopping online, ordering online, using virtual means of what, of doing her shopping. And that is even dependent on how tech savvy she is. Okay, this may be another barrier for patients that may not have skills that are compatible with a basic care technology. So now, from what we have seen, this actually gives us an idea of how we think in relating with patients when we talk about assessment. And this is not just limited to adult cases. When we are looking at children cases too, we can also apply these perspective to assessment or evaluation to children, because children, we know that their predominant occupation is play. So their performance, their play performance will become of much essence to us, and also the performance components such as their motor skill, the fine motor skill, the gross motor skill, the memory, the learning ability to follow instruction, all those things, and also other domain we still apply to them. So we see the centrality of OTPF to our evaluation. Now, coming to what we said at the beginning, where we established the fact that evaluation in the context of OT is more appropriate to our discourse, we can now see that evaluation incorporates interview, observation, measurement, testing, and evaluating against norms and outcomes. So interview is one of the ways we can also do our evaluation. We can gather information. So interview is no other thing than what is shared verbal experience that is jointly constructed between the interviewer and the interviewee. And as we know, as OT practitioners, our interview can be structured, semi-structured, and unstructured, details of which we will not be going into in this discourse. Again, our evaluation also involve what? Our clinical observation. For instance, you are dealing with a patient that is having mood disorder without even starting to engage the patient verbally. The affect of the patient, that is the countenance, what we call countenance, but which is what the mood of the patient that can be read on their face, okay, can already give us some idea of what the patient problem is. For instance, a patient that is depressed, you can see the presentation of the nasolabial fold on the patient, and you know that this patient is having this problem, or a patient that is having mania, without even talking, maybe the way the patient has done the grooming, combining different riot color and conflicting colors and all that, or being extravagant in the use of ornament and the use in terms of adornment. Looking at that patient alone at glance, just with your clinical observation, you are able to have the kind of a spot diagnosis, which you definitely have to validate with all that detailed assessment subsequently. So you can also see measurement is part of evaluation and assessment or testing. So measurement, when you are measuring using your goniometer to do your goniometrics, you are using your dynamometer to measure the grip strength, you are using your volumeter to measure the edema level. Okay, testing, maybe you are doing you are like the different hand functions like the Jepson, the block and pop text and all these are different forms of techniques that we engage in our evaluation. So assessment is just actually one of the evaluation techniques. Now, coming to the focus or the sub-focus of our presentation, which is assessment. Assessment refers to the specific method that is used to collect data, which is one component of the evaluation process, as I said before. So Assessment can be what? Initial, can be continuous, can be discharge, just as evaluation. So the one you do at the beginning of your engagement with the patient is the initial assessment, and the one you do maybe after, maybe like after you have exhausted like your short-term goal, or maybe you develop a treatment plan that, oh, this patient is going to be seen for the next 1 month after you, before you review the treatment intervention again. So the assessment you're going to be doing after that, those preliminary goals have been achieved, that's a continuous assessment. And when the patient is about to be discharged to the community to facilitate the community integration, you are going to be doing your discharge assessment. Now, all these assessments, you can engage either standardized or non-standardized assessment. Standardized assessment means that what it has, it is what it is an assessment that has a high degree of consistency, objectivity, reliability, and validity. And that brings us to the next topic, which is the psychometric property. So every assessment we are using, standardized assessment, we need to ensure that they are the one that have psychometric properties. So when we talk about psychometric properties, the word psychometric actually originates from the field of mathematics, which is used to describe some statistical data or inferential data, but we are not going to the details of that. But as it relates to our discourse, we are looking at the assessment you are choosing, does it have validity? And when we say validity, does the instrument you are using, is it able to measure what is intended to measure? Let me give us a very basic example. Many of us, we can relate with goniometrics. Goniometer is designed to measure range joint of motion, nothing more, nothing less. So you will not say you want to measure a patient grip strength and you are doing goniometric, okay? Just like your thermometer will not measure your blood pressure. So goniometer is measuring range of motion. So any instrument we are using, we need to ensure that what it has validity, and we speak to measuring what is intended to measure. Validity is actually about the quality of what, the stability of the tool or result given over time. For instance, if therapist A use the same instrument in the same context, in the same way, and with therapist B, they should be able to get the same result. Just like that goniometer. Goniometer is very what? Very, very reliable and valid. Why? Because if I'm to measure, for instance, shoulder range of motion, let's say shoulder flexion, and I know how to do it, I know where I need to position myself as an occupational therapist, where I need to position the patient, where I need to put different part of the goniometer, the axis, the compass, the movable arm, the fixed arm on the patient, and the anatomical landmark that should correspond with the axis. If I do all this under the same condition and blessing another therapist from another context, do the same thing on the same patient, we should be able to get the same, similar result with just maybe 5-degree error of margin, which is still allowed. So this, if an instrument has that kind of consistency, we say, okay, it is stable over time. And responsiveness is ability to detect change over time. For instance, you are engaging the visual analog scale. When the patient is being encouraged to rate their pain, with 10 being the most excruciating pain and 1 being the least, or 0 being or no pain at all. So as this patient's pain is resolving, maybe coming from scale of 9, 10 to 2 and another, it should reflect decline or progress in that pain. So that's what we refer to as responsiveness. So that's the ability to do what? To detect change in the reported impairment or what you are measuring. So OT specific, there are standardized assessment, as I said before, and time will fail us to actually go into these details because we can spend ages on this, but it has been categorized for us so that we can lay a hand on this and engage them. So if you have to assess perception or cognition, you can use the MOCA, which is a very popular one, the mini mental state examination, and others that are listed under that. If you are looking for a standardized assessment for activities of daily living, we have functional independent measure, the PAT test index, the assessment of motor and processing skills, self-care evaluations. If you are looking for assessment of motor skill and coordination, you have the Bruning's statistics, and you have the Jepson Taylor, you have the 9O, the block test, the Peabody, and many others. So the list of standardized assessment in occupational therapy is almost endless. And coming to pediatrics assessment, you have a pediatric evaluation of disability, of inventory, a disability inventory. You have the sensory profile, the one we often use in sensory processing disorder, in autism, and other condition that has to do with sensory integration problem. Okay, there are also specific assessment to sensory processing and integration, such as the SIPT, that sensory integration practice test, and other sensory-based intervention, assessment that I've actually outlined on the screen. In addition to this, we can also assess for client-centered and occupational performance. So they are specific, and some of these are actually stemming or they are offshoot of particular model. For instance, the Canadian occupational performance measure is actually a product of that model that has gained acceptability in the OT practice. So we can relate to this after the discourse and engage them when the need arises. Now, when we are assessing our patient or when we're doing our evaluation, we come across different categories or patients or service users that may have some peculiar presentation that will warrant special protection be given to them. And some of these clients may require, may need protection, and some of them include those that are having dementia, a patient that is having dementia, delirium, or confusion. Depending on what they're having, for instance, delirium is more temporal compared to dementia, so they may not have the awareness, their orientation to time, place, and person. They may not be aware of even their knowledge of safety. Okay, their safety awareness may be affected at that point in time, and that places a lot of challenge or risk on their safety. So it is expected of us that we should be aware of this as practitioners and ensure that necessary protection. What about a patient? For instance, a patient that has become a condition, maybe lying flat in a hospital bed for like 3 to 4 weeks, has not done a bed transition, like from lying to sitting at the edge of bed, or even doing sit to stand to frame or to stick or any move or any standing aid. This patient, you need to be aware of the fact that trying to get them to rise up from lying suddenly to sitting can actually trigger postural hypotension, and the patient can have disease or even go into syncope, so just pass out, and that may become an issue, an emergency issue that may mar your engagement with the patient. So you need to be aware of this. What about patients that are hallucinating? This is very interesting to many of us that have worked in mental health. You may have a patient that are having visual or auditory hallucination. They have comment, voice giving them comment on what to do. Or there have been instances of a patient that this hairdo that are female professional wear, is it Bob Marley or attachment, long, a patient that is hallucinating, saying that as a snake on the therapist's head may want to make an attempt to kill the snake just because that's what he could see. So we need to be aware of the content of the hallucination and also give them, and some of the hallucination can make them to be either suicidal sometimes or homicidal. They may want to inflict injury on themselves or hurt others. So that's why we can't afford not to give necessary protection. So some of them may be having behavioral changes. They may become anxious, fearful, apprehensive. They may be withdrawn. Those that are having maybe personality disorder or social isolation or depression. And what about the elderly patient? These are also categories of patients that require special protection. That is, they may be having decline in their vision, hearing, or they may be having general fatigue, or they become frail. So this will help us to know how we need to protect them and to put the necessary measure in place to help them, to protect them. Now, we will just want to touch on specific ways we can grant them what protection. For instance, dealing with older persons with decline. I'm on slide 33, please. Slide number 33. Okay. Decline in vision or hearing. Okay. If a person can't see you or hear you well, most of the sensory cues that convey interest, like what alerts, you have to what, when your patient cannot see, maybe you are dealing with a patient with declined vision, so you need to engage other sensory to try to maintain high contact with the patient, ensure that you have a kind of get their body attention. Again, show some kind of gentle touch as may be allowed in the context of the practice, respect. Your voice shouldn't be the one that is too hard. Sometimes many of us relate with a patient like more or less like master servant. Here is the savior, and here is what the one that need the salvation, so to say. You are healed, I'm the healer. So all those mentality that is stemming from medical model of engagement should not be seen in our practice. So we need to show respect, affection, warmth, concern, confidence, and constant reassurance. Okay, and again, dealing with older patients that may, to compensate for their vision, we have to wear at the point, maybe you have to see them on the ward, or you have a particular time set for their assessment or their evaluation. Wear bright color clothes. Do not sit with your back to shadow, or wear bright or other bright light, because you are going to cast shadow on the patient's face. Avoid anything that might distort or hinder your face feature. For instance, those of us as practitioners that were in the habit of chewing gum or hand in front of your mouth when we are talking, all those kind of gestures or mannerism that can actually give another make communication with patient to be misconstrued. All those should be are avoided. Again, sit as a close arrange to the patient when you are interviewing them, and keep your face visible to maximize the communication cues. In addition to this, use touch appropriately, but this is actually context dependent. Okay, a light touch on the hand or arm can signal to another person to ignore other distraction or to redirect their attention. So all these are ways we can manage all these special features in them that calls for special protection. Again, to compensate for hearing, okay, sometimes in our context, you hardly see old people coming with hearing aid, but in other maybe well-developed or more developed contexts like the UK or the US, they have easy access to all this. So that may not be a big challenge, just to ensure that they wear their hearing aid. But in our context, whereby we may not have that kind of opportunity, you have to engage other strategies, okay, that we have spoken about under the compensation for visual impairment. So you can enhance your communication with non-verbal cues such as facial expression, body language, and appropriate use of gestures. Many older persons have better hearing in one ear other than the other. So you need to ascertain that at the beginning of your assessment and speak towards the head that they are not hard of hearing. Again, still on the protection for those that have the risk of fall. You have to ensure that your patient is on the right footwear. Sometimes when patients are on the wrong footwear, maybe oversized, or the one that the sole had already found has eaten up at a particular sole, which is going to make them to easily fall. You need to ensure that that patient will not go on that. Maybe when you have to engage them either in the ward or in your clinic or wherever you are assessing them. Again, ensuring that they are wearing non-skid rubber sole, low heel shoe, using the right assistive device. This cannot be overemphasized, and I'm sure our physiotherapists, a colleague can speak volumes about this, because I'm sure they have the experience, or they see this more in practice with their patient, because since they are more involved with patients that may have mobility challenges more. So standing up slowly, getting up too quickly can cause, for instance, as I said before, a patient that has been deconditioned or that has been bedridden for a very long time or been lying down. And it's just unfortunate in our client that we don't do this routinely. But ideally, when the patient has been lying down for hours, like 24 hours or even close to 48 hours, before you make that patient to transit from lying to sitting, ideally, we are supposed to do to check the blood pressure, because that can signal what the patient is dealing with and tell you either you have to mobilize that patient out of bed or not. So we need to be very conscious of that. Find out about the side effect of medication. Are they on medication that make them to be drowsy, that affect their attention span, or those that are like muscle relaxant that make them to become weak, affecting their muscle strength or even muscle tone. So, and if you are making them maybe to do an activity that involves like assuming some fundamental position, maybe rising from sitting to standing, engaging them on stunning tolerance activity. If you don't understand what they have or give them this special, you are not aware of what medication they are, you may not be able to give them the necessary protection. So it's very important that we ensure that also the patient gets enough sleep for those that are like inpatient, confirm if the patient has just been thrombolized. This is very important, although it may not be a very common experience in most of our public hospitals, but in private hospitals whereby they do thrombolysis for patients after stroke. You know, it's a rule of thumb that at least 88 hours post acute thrombolyzing of the patient is not supposed to be mobilized out of bed because you actually putting the patient at risk and the patient can fall and a lot of complication or casualty can result from that. And the patient that is having fatigue, you need to engage energy conservation technique. For instance, if you are going to do a task-based assessment, are you going to, you may have to engage what we call shaping or chaining. For instance, an example, backward chaining or forward chaining. So as an occupational therapist, since you know that this patient has a tendency of what's becoming tired or fatigued, you may have to start the task and ask the patient to complete it or look for the best time in the day where the patient have the highest level of energy to engage. So these are the special protection that you can give to your patient. Now, coming to the interpretation of our result, the data from various assessment tools and techniques are synthesized for problem identification. So as I said before, that's why I was more comfortable using the word evaluation. So what you have done through your measurement, what you have done through your testing, what you have done through your interview, what you have done through your skilled observation at the level of interpreting, this way you synthesize them together, bring them together to make what a conclusion, make an interpretation. So functional capability of the client is kept in focus. So as occupational therapists, we are not just concerned, this patient does not have a full range of motion of shoulder flexion 0 to 180 degrees. How has that impacted the donning of the cloth? How has that impacted the patient's ability to handle the chalk as a teacher to write on the chalkboard? How has that impacted this patient occupational profile as a teacher or as a farmer that needs to weed the farm using the shoulder movement to clear the farm? So all your observation, your assessment, your measurement, your testing should culminate into functional interpretation. So a sound knowledge of evaluation process, specific assessment method, and clinical reasoning are key to accurate interpretation. So irrespective of the assessment you are engaging, the bottom line is that you need to understand the details of that assessment, and our knowledge of clinical reasoning also is being brought to bear to interpret all this, because most of the time what you are measuring will come to you as what numeric value. For instance, a patient that has cognitive impairment secondary to stroke, and you have done your MOCA, the monetary cognitive assessment for that patient, and the patient has scored 18. What does 18 mean? Looking at 18 on the paper, maybe the patient did not do well at the visuospatial area, or the patient, that's the aspect of delivery, or the patient has not had a good score. That does not make any sense. But being able to interpret it that, oh, this patient having a score of 18 and the minimum benchmark is 26 over 30, as an example. 18 will mean what? From 18, between 18 to 25 or less than 26 is what is suggestive of mild cognitive impairment. Now it will give you the signal that this patient, you need to monitor the impact of that score you have just interpreted on how does this translate into what? Navigating the functional mobility, indoor mobility. How does this culminate into what? Outdoor mobility. If this patient goes out from his house, maybe to shop in about 20 years or 30 years from his or her house, would this patient be able to return back home? Or as a result of what? Topographical orientation of the patient that must have been affected based on the performance on the visual spatial component of that MOCA assessment. So it is at the level of interpretation that you are able to bring out the functional implication of how does this delay recall, inability to recall, how does it affect the patient's ability to manage the medication? Because this patient that is going to be discharged will be discharged with certain medication that will correct the underlying pathology. But a patient that is having problem of memory or delay recall may not know the right dosage to take or the appropriate. So that will also help you to now begin to evolve strategy. Are you going to have a kind of an alarm or connect the patient medication to the what we call 3 scheme, which is 3 is never square, as we say in Nigeria? Okay. Are you going to attach it to a particular event that you know that the patient has already developed over time as automatic activity? Do you understand? Or in a climb whereby they can afford what is called Dorset box or what is called a blister pack, whereby the medication per time is sorted in like a kind of a box that has segments for different dosage per time or different days. So your interpretation of that assessment is what will signal to you and give you the understanding of what strategy that the patient will need. But you have to interpret it in terms of functional, I mean, the impact on the functional capability of the patient. And your interpretation again can signal another test. For instance, you've done your MOCA, okay, which is like a paper-based standardized assessment. We now want to do a more functional assessment. Okay, is this patient able to do wash and dress assessment? Is the patient able to do kind of cup of tea to know how the patient problem solve, the safety judgment in terms of handling the hot water in the kettle, and is this patient able to manage the depth perception in terms of pouring the water from the kettle into judging the depth of the copper, right, without spilling the water on himself. So your interpretation should always be done within, in relation to functional implication and performance. Slide 38, please. Now, what are the essential considerations in our interpretation? We need to do ensure that you collect comprehensive data, because AFOSAT data will definitely lead you to information or interpretation that is not appropriate. Comparing results with norms value. As I said before, for instance, maybe you are doing, even if it's manual muscle testing, you understand, you can only say this patient is having poor muscle strength just because this patient, the normal is that this patient should be able to do what? Tolerate maximum resistance. The joint should go through maximum, the full range of motion, and it's against gravity. So the normal value for normal muscle strength is 5. So anything that is lower to that the patient performed with respect to those parameters of gravity, resistance, and range of motion, you can compare with that. Or for the example of cognition that I mentioned, okay, a patient that score below the score of 26/30 in MOCA is definitely 18 to 26 is having mild cognitive impairment, or you have used even the one more generic one, the GCS that we often engage in terms of dealing with our patients that have altered consciousness. You know that any score that is between 0 and 8 is a very severe TBI. 9 to 12 is moderate, and this thing 13 and above can be mild or no altered GCS. So what I'm trying to say in essence is that the performance of the patient is always reconciled with norm reference that have been judged normal for the patient. Identify patterns and trends. What is the pattern that the patient is maintaining on that assessment? That can signal or give you understanding of what the real challenge of the patient is. Evaluating the magnitude of the impairment, considering the whole patient. As I said, occupational therapy, we've always won the lens of holistic assessment in our patient evaluation, not just dealing with the impairment, but looking at how the impairment impacts occupational performance and also the context in which the patient will have to live or to engage. Again, you continue with monitoring the progress. Next is slide 39. Slide 39. So method of scoring standardized assessment. Each standardized assessment has its own unique scoring method. So there isn't any formula or one size fits all strategy to scoring standardized assessment. That's why a good knowledge of the assessment before you engage it is very important. And the list that I gave us, we can go through it and do some specific detailed study. We can see how they are being interpreted, because this time will not suffice for one to reel out how each of them should be interpreted. The ratings are based on performance rather than capacity. As I said before, performance are compared with norm reference. Clinical decision inferences are made based on how the performance compare with the rating or normative value. Okay, and examples depicting these points are listed in the application of MOCA or the functional independent measure. So having said this, coming to bringing all our points home, can say that an accurate and comprehensive evaluation is critical to a successful rehabilitation evaluation and intervention. beg your pardon for that. Protection measures are very essential in OT engagement with clients, and OT should know the right strategies to engage per time. Occupational therapists or OT practitioners can improve their knowledge in evaluation through continuous learning and on learning, because there are some things that we've learned over time to do in the wrong way. And that actually underscores the importance of the effort or the workshop that the MRTB is continuously putting in place, which I will encourage many of us to avail ourselves the opportunity, because this is very germane and important to our efficiency in terms of evaluation, not only evaluation, in the overall intervention of intervention plan for our patient. So thank you for listening. Any question before I take a leave, please? And these are my references. Can project the reference and okay, can go to the title slide again, please. Thank you.
Thank you so much, Mr. Lainde, for this presentation. Even though your timing was not as scheduled.
Hello, sorry
Thank
about
you
that.
for
We had
efforts to making this
some delay in
presentation.
getting the project.
For
Can you hear me?
comment or contribution can be asked to unmute. I can hear you, sir.
All right. Okay, so apologies for that. Trying to, I think we spent some time on getting this thing projected and all that, but I take responsibility for that. Sorry about that. All right. So please, in the absence of any question, I may have to leave now, as I've discussed with the moderators of this and other co-presenters of this workshop. So thank you for listening. God bless you all.
Mommy. I want to down here. A woman, and the work than only does.
Sir, your name is not appearing.
That's strange. Oh. This is strange.
Okay, well, the user is sharing screen. No problem. No problem. Since you can share.
I'm looking for it and it's not coming on yet. Yes. Okay, since I've sent it to you, can you share it? Can you share it?
You cannot unmute because we put.
Oh, okay, I was asked to unmute.
Sir?
Yes.
You can unmute, please. I have unmute everybody.
Okay, I've now unmute. And it's showing green saying that you are sharing, you are screen sharing.
Yes. You are supposed to be able to. The host is informing me that. Right.
So what's the host saying?
I'm giving him instructions to make you a co-host now, sir.
Okay.
I think your username on Zoom is user.
Yeah, I think that's what you think. Okay, it's user. Okay.
You are co-host already, sir.
So it's giving us a whole lot of issue.
Okay, sorry about that.
Because typing using
You are the co-host already, sir.
I'm the co-host already.
Yes, sir.
That's very good, sir. Yes,
Okay, I'm trying to go to documents now to fish out my file. Oh gosh, so slow.
Okay, please kindly be patient with Professor Wolawi. He's trying to get his file out to be shared. Thank you.
It's not correct. What's happening here? Okay. Can you see it now? Hello?
Yes, sir. Yes, I can see.
You can see. All
We
right.
can see your screen, sir.
Okay, okay. Thank you very much. Thank you. All right. Good afternoon, everybody. My name is Dele Owolawi. I'm a professor of audiology at University of Medical Sciences, Ondo, Nigeria. Medical rehabilitation assessment. I'm going to look into the audiology perspective. Am I communicating? Can you still hear me? Can everybody hear me? Hello?
We can
Hello?
hear you loud and clear.
You can,
We can hear you.
okay. All right. I'm looking at it from the perspective of the scope of practice. So we look at it from pediatric aspect and of course the adult patients as well. Basic case history in pediatric cases, I will start with that. I will also take a look into an area that is very relevant to audiology, which is tinnitus, ringing in the ears, and dizziness. So we take it from there. Now in pediatrics, in most clinical practice, assessment is often obtained either directly from parents or guardians or carers, because we know that in pediatric cases, except when the child is matured enough or old enough to narrate his or her own history, the information about the child has to be obtained from parents or guardians or carers. Now, what are the reasons for this? One is necessary for a child to be part of the process of assessment. The child, if he's able to communicate, needs to be given the opportunity to be an integral part of the assessment by narrating his own issues or our own issues. Secondly, is to informally assess the language and speech level of such a child in comparison to age or physical or mental growth of other so-called normal children. This gives us an insight into mental development, of course, also physical development. We may have some children who have mild mental retardation or they are autistic or what have you. So this gives us the opportunity to listen to the child and also to look at the pitch of the child, the pitch of the speech of the child, or if the child has speech or language or not, to be a determining factor. Now, the comprehensive evaluation from audiology perspective, conducting a rehabilitation assessment involves one, a comprehensive evaluation to understand an individual's hearing loss. How does this occur? This occurs in the sense that when a child has a hearing loss, depending on the site of lesion or site of damage, if it is conductive, we have three types of hearing loss. Basically, conductive hearing loss, mixed hearing loss, and of course, sensorineural hearing loss. So if the impairment is localized in the conductive component, the child is likely to speak in a very low tone because of what we call the Lombard effect, echo, sort of echo effect, so to say, because the child is actually hearing through the bone of the skull and the sound is too excessive. So there's a tendency for the child to speak in a very low tone. But if it's a sensorineural hearing loss, or basically sensory hearing loss, which is located in the cochlea, this child is likely to raise his or her pitch and talk in a very loud tone. There's a possibility that each person will want to modulate his or her voice when talking, and there's a feedback system which is transmitted through the cochlea and through the auditory nerves to the brain. So when there's no input in the inner ear, there's a tendency to raise one's voice. This is common in the elderly people. We'll talk about that as we talk about presbycusis. Now, this ultimately guides the development of a personalized rehabilitation plan. The first thing is that when you listen to the speech of the child, it can give you what we call a provisional diagnosis. Oh, this child is suffering from conductive hearing loss. Well, by the time you even pick up all your tools to carry out examination, you have an impression whether the child has a conductive hearing loss or sensorineural hearing loss, as I said. And if the child raises his or her pitch and make it too loud, of course, that is a tendency or an indication that the child will probably be in need of a hearing aid or a cochlear implant before you quantify the extent or the degree of the hearing loss. Now, the initial assessment and history will be bordered on the following aspects: prenatal, perinatal, and postnatal. In prenatal history, the clinician will have to question the pregnancy state and progression. It's only the mother that can offer, that information during the gestation period. Was there any problem in terms of illness? Was there any issue, especially during the first and second trimester period when the auditory system is actually thriving. Questions like exposure to X-ray or radiation or chemicals are to be probed into because this is known to cause some damage prenatally. Particularly, that's why when a pregnant woman is asked to go for X-ray, one of the questions the radiographer will ask is that, Madam, are you pregnant? If you are pregnant, they want to know how many months. Is it first trimester or second trimester? Because radiation can actually do a lot of damage to the unborn baby. So that's very, very critical. Now, it is essential to rule out any radiation-induced damage during the auditory developmental stages, which I have mentioned. Another area to query is medical and concoctions, that is medically prescribed, some medications that are prescribed during pregnancy or concoctions personally consumed during pregnancy. There could be some toxic effect in some of these medications. There are very powerful antibiotics that can actually cause a lot of damage during the pregnancy. So a pregnant woman should take time to see a qualified O&G specialist and refrain from taking just any medication or consume any concoction that may be counter productive in terms of the growth of the baby. Now, this is to rule out prenatal ototoxic auditory induced damage, ototoxic induced auditory damage. This is the reason why in the case history form, there must be some questions related to medications that the pregnant woman must have taken during pregnancy or some concoctions made by local people, which may actually be detrimental to the development of the auditory organ. Genetic factor. Yes, we all know that there are genetic factors in healthcare, particularly in human beings and other animals, so to say. So it is essential to find out if there is any history of family or familiar hearing loss, whether in grandparents or uncles or aunts and what have you, because this can be carried over and it will impact the unborn baby. So it is to know if there's any genetic undertone causing hearing impairment within the family. This is always a bone of contention between husband and wife. Most times we do have that incident when they come to the clinic. Some fathers may say, well, I don't have any problem with my family. It must probably be from the mother's family. And the mother will also accuse the father, and it keeps going back and forth. So we need to be able to establish and to be able to explain to them that it may not actually be from the parents, but it could be from any of the family tree members, like grandparents and what have you. This is very essential to know. This is particularly required, particularly in cases of consanguinity, family members who marry themselves. It's not very common in our culture, but it is very predominant in some cultures, particularly in the Middle East area. Now, other history will include maternal alcoholism and or excessive smoking. We all know that cigarette contains nicotine, and nicotine is one of those things that actually constricts the blood vessels, and it also causes cardiovascular problems. And of course, what affects the transmission or distribution of blood circulation, rather, may also affect the cochlea, which is the organ that is lives with ability to hear. Then high blood pressure is also a factor. Trauma, venereal diseases like syphilis, herpes virus, German measles, diabetes mellitus, anemia, and of course, oxygen deprivation. Whatever affects the mother during pregnancy has a potential of affecting the fetus or the unborn baby. So this has to be looked into in the history or assessment of any baby who has hearing impairment. Then perinatal factors. This equally serves well to ascertain factors such as delayed labor, neonatal anoxia or birth asphyxia. Audiological assessment will also question if delivery was by forceps. Why do we question that? This is because forceps may cause a little damage to part of the temporal lobe where the auditory cortex is located, if not expertly handled. We have all sorts of clinics and hospitals around. People who are not experts tend to dabble into areas that they are not experts in, and this may actually cause some form of damage, which will affect the area where the cochlea is located in the brain. That's the auditory cortex. Postnatal factors. Any post-delivery sepsis and incubator placement for more than 29 days is expected to be on the list of things to be investigated in the course of assessment. Yes, incubators also generate a lot of noise, and if the child is kept there for a longer period, it may actually result in early noise-induced hearing loss in such a baby. So, but these days we have noise-controlled incubators, which is quite different from what it used to be in the past. But in some institutions or medical institutions, they are still stuck to the old incubators, which generate such a level of noise that is above the decibel level. So we need to look into that aspect as well. Neonatal jaundice or kernicterus, especially with exchange blood transfusion, is very important for an audiologist to query in the assessment protocol. We all know the damage that neonatal jaundice, particularly if it's very severe, that it causes blindness, it causes hearing problems, and so on and so forth. So we need to find out if the child had neonatal jaundice and it was so severe that exchange blood transfusion had to take place. Now, history of delayed cry. We all know that oxygen deprivation can also cause a brain damage, which of course, when there's a brain damage, it may also result in auditory deprivation. Low ABGAS score, neonatal seizure, prematurity, low birth weight are also put into consideration when carrying out the assessment. All these factors tend to have an impact on the auditory function or potential. Now, part of the postnatal factor is also syndromes, visible syndromic evidence. This is visible. We can see there are some hidden syndromes, but majority are visible, like Klippel-Feil syndrome, Hunter syndrome, Usher syndrome, Waardenburg, craniofacial Down syndrome, and so on. These are all visible syndromes that we can see. And of course, when this is shown or when it manifests, there's a tendency to know that these syndromes also carry a genetic code of hearing. It could be mixed, it could be sensorineural, it could be conductive. The majority of them, sometimes we found out to be sensorineural hearing loss, with the exception of Down syndrome, which is mostly middle ear problem. And of course, other features are there. Then we look into the history of measles, meningitis, mumps, chronic suppurative otitis media, that's infection of the middle ear, unknown febrile illness. All these things need to be incorporated into the assessment form so that we can have an impression of what might be the etiology of the hearing disability or hearing impairment.
Please let's exercise little patience. It's like network log out the facilitator. Thank you.
وشوكاتهم متدرج لا أصلا
So I come this class.
still trying to is
They are still there. 48 people.
Good afternoon, everyone. Good afternoon, everyone. I hope I can go on now.
Good afternoon. You can go on, please.
Yeah. Thank you for attending this workshop. It's been a long day since morning. I will try not to repeat what my colleague talked about. So while I was listening to the presentations, also so that this presentation don't appear too repetitive, because at the end of the day, we should all be looking at the patients from a perspective that focus solely on the patient, where all of us jointly contribute to the good outcome of our patients. So when we talk about the documents that looks at the overall content of what this seminar is supposed to cover, you will see that we have lots of things in common. Because at the end of the day, we are all looking at the same patient who need our services. Even though we are all looking from our perspective, but it is still the same patient that we are looking at, and it is important for us to make the patient our priority. So I am not going to go into so many things, but rather to just do some paraphrase, then similar to my colleagues, go into cases that unified us rather than cases that look at my perspectives or any other person's perspectives, so that we can see where do we come in all these. So I'll make sure these slides, actually, I don't have more slides because I would rather go into the cases. So let me quickly move on. So sources of information for gathering the person's history. My colleagues have talked extensively on them. Families, carers, records, the incident. Since morning, these are issues that have been beaten down by others who have presented earlier. The type and purpose of information to be collected is very significant, which can be disease factor oriented or the condition oriented. When I mean by disease factor, I'm seeing a child with hyperthyroidism which is very significant. And I'm also seeing a child with autism, also very significant. So the type and purpose of information that I'm going to collect from a child that I'm dealing with hyperthyroidism, severe respiratory problem, contractures of extremities, severe hypotonia is different from type and purpose of information that I'm collecting from a child that is on the autistic spectrum. Type and information also can be related to the duration and the extent of damage in every individual. Yes, again, I saw a child who started having back pain 2 years ago, being treated somewhere. The X-ray and the analysis of the spine shows the corpse angle at 13 degrees. 2 years after, despite therapy, the corpse angle have risen to 20. So the information 2 years ago, what makes the difference? One, what is the age of that child and how long has it been there? Those who are handling that child should know that a child that is 14 years old now probably started the back problem at the age of 12 and is still growing. the spine will change, the body features will change. So any assessment that is done for children can only be temporary because they are still growing. So you don't have a static situation in children, teenagers, adolescents. When you get to adult age, you must see a little bit of adaptations and changes or stagnation in terms of changes of patterns. But for children, you must understand that the child that I see at 6 months, and I'm seeing at 6 months later, it's not the same child. Something has changed. However, if you continue to do exactly the same thing, then one needs to query what you are treating. To treat a child for 6 months, doing exactly the same thing, the same feature, not seeing any changes, something is wrong somewhere. Either you aren't looking at what you should look at, or you simply believe you are not, or you don't know what to look for in terms of improvement, changes, or you are using the wrong outcome measures. Because sometimes I've seen people who use outcome measures in a totally wrong place. Again, type and purpose of information to be collected can be related to abilities and its inabilities. Because at the end of the day, in rehabilitation, our key to rehabilitation is to promote functioning so that individuals' abilities, functional abilities, is important. And when we are looking at the functional abilities, what can he do and how does he do it? That's the most important thing. How is he doing it? Why is that important? Walking is an ability. And we can say gait rehabilitation is an intervention for that ability. But it makes a lot of difference. You wrote in the folder, patient can walk. However, in your intervention, you are talking about gait re-education. Because you've already written an ability, which is patient can walk. Then what is the need for gait rehabilitation again when you already say you can walk? But it will make a lot of difference. If you say patient can walk, but walk with equinus deformity and contractures in the arms and elbows and ankles, then one can understand what you are doing with. Yes, he can walk, but he has other problems. But to say patient can walk, and yet we are still talking about gait re-education, rehabilitation, it doesn't fit. His inabilities is also key. And when we are looking at patient's inabilities, then you are looking at what are the reasons for his inability in same patient. So you plan management to improve his abilities and plan management to mediate things that contribute to his inabilities. Because at the end of the day, what we want is functioning. Type and purpose of information collected also will vary. Assessing the patient in a teaching hospital for a rehabilitation. We take a different meaning if you have to assess a patient inside primary health care, inside rural areas, for rehabilitation and integration. But the circumstance and context will be different. So purpose of our assessment, we can summarize it that we are looking for what is the main problem this patient has. In rehabilitation, the longer the impairment stays, the more compounding the likelihood of things to look out for. So identifying the key issues, the baseline factors, and finding key issues is key when you are looking at complicated cases, which often is what you are going to find the person is living with disability, especially if the disability starts from childhood or developmental disorders. It means this person has been or was born with this problem. Even though this problem stays the same, but as they get older, other confounding problems arise that needs to be treated. So the impact on children is totally different from adults.
Sir, your slide is not moving.
Yes, I'm still talking on one slide.
Okay, sir. Okay,
I'm
sir.
describing on the main problem, why we look for key issues and baseline factors. So, what are key issues? Key issues is something that might impact upon your assessment and treatment. Something that might impact positively or negatively upon your being effective. A key issue might be a family problem. A key issue might be non-compliance because of beliefs, late diagnosis, or late referral. For a child, often what we are concerned about, what does the future hold for this child? While for an adult, is fear of being handicapped, not being able to cater for their family, loss of income, loss of independence. So the mindset and assessment for children is totally different from the mindset in assessment for adults because it's going to impact them differently. Baseline factors is the one thing that could be changed that will impact positively on the overall treatment outcome. It might be a mental, cognition, or perceptual problem, or loss of sensation, contractures, and deformities. Why is baseline important? In many instances, when we are dealing with persons with disability, they have lots of comorbidities, challenging issues. But when you look at the whole problem, it can get compounded. For instance, maybe I'm seeing a Parkinson patient who has high blood pressure, is diabetic, so he has neuropathy, food. And he's got visual problem. What is the baseline factor? Vision impacts the way he moves. If he can't see properly, he probably wouldn't walk properly. But he's also got Parkinson, which naturally gives him a shuffling gait postural imbalance that I need to deal with. But it's also diabetic with neuropathic food, and it's hypertensive. Each one of these, we must look at what is the baseline factor. What are we saying here? What one thing can I change that will change the overall outcome and guide his progress better? This way, I will set my intervention priorities and plan intervention appropriately. The third question is indication that the person is in need of protection measures and how these are initiated. In consent taking, we have handled a lot of these issues, but we cannot overemphasize it. I was talking with some of my junior colleagues this morning about this issue of vulnerability, and it's important. The first thing is assessment of vulnerability. We need to be able to assess the individual vulnerability, the capability to make decisions, also including their conscious level, their judgment ability, which include their cognitive and mental, emotional problem they might have. It's also significant that if a patient is not accountable to self and others, they are vulnerable. And we need to protect them, because if we protect them, we protect the community, because they are not in control of themselves. It's about one sees a patient that have mental, emotional issue, and you decide to pick a fight with him, not taking the right steps to avoid him in a situation of confrontation. Everyone that is looking at that person will probably be feeling maybe both of them are the same, because they know the person whom you are arguing with is not accountable for himself as well. So assessment of vulnerability is important. But who is a vulnerable person? The vulnerable person is or may be in need of hospital, community care service, by reason of physical or mental disability or other disability related to age or illness. The vulnerable by reason of being unable to take care of themselves, or unable to express themselves, or unable to protect themselves against significant harm or exploitation. Vulnerable children, 0 to 13 years, adolescents, 13 to 18 years, adults, over 18 years. Capability to make decisions. In this instance, as professionals, when we are dealing with patients that we suspect are incapable of making decisions, the principal provider needs to be knowledgeable enough on the condition that the patient came with. It might not be a mental problem, it might be a physical problem, the progression and the outcome, and relate it with the fact that this patient can make decisions. That's important. It's difficult to give an home program or follow-up program for a patient who does not even have cognition to follow through the instructions you are given. We also need to understand intervention and assessment of rehabilitation domains. The following will be highly significant: mental, emotional, perceptual, and cognitive function, sensation, sensory functions, and mobility, swallowing and oral hypersensitivity, cardiac hematology function and respiratory functions, emergency situations and drugs that can affect person's judgment. Family social factors can also play a significant role in influencing patients who have poor decision-making ability. You must be able to assess all this because the impact or worsen in situations when the patient can't make decisions for themselves. How do we initiate protection for vulnerable persons? It's good practice for vulnerable individuals to be protected. Good practice about the way we carry out our duties and responsibilities to others. Good practice framework required consent and adequate information being shared. Dignity in action and dignity in care, which calls into our professionalism, ethics, empathy, decorum, protection of vulnerability. Including letting the patient or carers understand the best and applicable intervention rather than imposing what we are as being the only choice the patient has. Client-centered practice is important when we are dealing with all these issues. Understand patients' rights, individuality, and culture. We need to respect their cultures and norms, respect their values and religion. Also, we don't disclose the patient's information except if this disclosure is related to their health and should be disclosed to those who needed it most. Like I said, in consent taking, we have handled a lot of this aspect. We need to tidy loose ends of emotions, anxiety, and understanding of the situation. There are also legal framework that was extensively dealt with in the taking consent for rehabilitation. This aspect was presented by a lawyer. Disclosure of information to appropriate persons and carers. Obtain consent, explain procedures, purpose, responsibilities, risk, benefit, and context. You need to have a roundtable discussions in protecting people. Never assume they understand your explanation. Never get tired of explaining situations. You will need to explain again, no matter how many times you have done so. Belief, culture, and social circumstances influence response and adherence. You need to engage with the person and family. These are core principles in rehabilitations. Parents' carers evaluation is important if they can be able to cope and what aspect they can cope with. It's not enough to give an home program to a grandmother who cannot even apply it. Or giving an home program for a patient who does not even understand poor literacy or poor cognition of what is being taught. Study the family background to navigate individuals or groups associated with decision making. Explain vulnerabilities, need for protection to them. Explain why the patient is vulnerable, why they need protection, both for themselves and for the patient. Be truthful but cautious. In the early stages of rehabilitation, most patients, relations, carers are still at the stage of denial. Therefore, provide as much as they are ready to accept. Giving overload of information can be seen or can be counterproductive. In some instances, when they are still at the stage of denial, they will likely tell you, I reject it. And there's nothing you can do about that. You don't force people to accept what they don't want to accept at that moment. Explain impact of specific inabilities and importance of rehabilitation and expected cooperation to have successful rehabilitation. Describe in detail the objectives and goals of specific intervention to families and issues. Provide aims that is clearly justified. Answer all questions to provide assurance. Aim to solve problem faced during functional recovery, required activities, and rehabilitation procedures. Provide a structured guidance. Home program is not an expert program. It's not for you to make the relations an expert in rehabilitation. So give as much as they can be able to cope with, to support and sustain progress, and set appropriate period for reviews. Steps of follow in protection of right. Record the patient under protection book. Client's record keeping. It can be departmental, organization, or MROTP. Patients who are under protection. Indicate the type of challenge they are. Disclose early to them if they understand it, to carers and to organizations of their vulnerability and their liability to themselves and to others. Monitor and support. Communication is key. Language, or if you need an interpreter, get one. Regular reviews as circumstances change. Engage in mediation, counseling, and care coordination. Sometimes chaperoning is important. You don't want to treat a lady who is emotionally unstable, and you are both in the same room just for you to come out and say she has been abused or she was fumbled in the wrong way, and you are wondering, what have I done that would have violated your privacy? But it's your word against the client. So sometimes having a chaperone, having someone, a colleague or an attendant in the same cubicle while you are treating some cases is best for your own good. There is also abroad what we call offenders record, as those who have been convicted of abuse of vulnerable persons in the past. Method of assessments. Again, I've heard a lot of my colleagues dealt with that. I'll just chip in one or two words. History taking is important, both informal and formal observations. How, when, and what, where. Assessing lying, in sitting, in standing, functional activities. Observe, listen, feel, and in infants, play is one of the ways to assess level of cognition, level of dissociation with self and environment. Profiling is important. To have structural, functional, and static profiling. Fitness and flexibility. Check both movement in static and dynamic way. Mental cognition and emotional is also important. Some assessment measures, again, I don't want to go into this in so much detail, but this is just for us to see goniometer, inclinometer, tape measure we all use this across board in our specialties. We use other analytic equipment, 3D motion analysis, photographs, electromyography, force platforms, pressure insules, dynamometer, spirometer, balance and endurance measures, basic skills. What are the assessment options relevant to scope of practice? Again, we have range of practice within each specialties, within each group, in physiotherapy, in OT, in OP and O. Got several areas of specialties, which will also show the history, and their plan will be based on the comorbidity and the morbidity that they find. It can also be age specific, because assessment is age specific, especially in children. What I assess in a neonate is different from what I'm assessing in a 1-year-old. What I assess in a 1-year assessment is not a teenage assessment. The reason for assessment is totally different. We can do, our assessment option can be educational purpose. It can also be for vocation and skill acquisition. Like I said, have assessment different for adults and children. Childhood assessment is age dependent. The adaptation domain is also important. The ICF is key in our assessment and planning of intervention. The ICF also helps us to determine patient rehabilitation needs. In the past, we look at short-term goal and long-term goal. But there's no long-term goal and short-term goal in quality of life. So in rehabilitation, right from day one, irrespective of the level of recovery of the patient, quality of life is key for us to maintain. So we set all our goals on maintaining, sustaining quality of life. There's no short-term goal to when we should have quality of life. Quality of life, irrespective of the situation, is statutory. Even if the patient is on palliative care, quality of life must be sustained. Use classifications. Classification is good for communication, and we have lots of classification for different ailments, different conditions. Diagnosis is important. Prognosis is also important. Then plan intervention. Classifications help us in our research, epidemiology, and comparison. Generally, the first classification of all types of outcome measure was done in 1993 by Donovan, which classified all outcome measures under 6 main types as general health measures, measures of physical function, pain measures, social health measures, quality of life measures, and specific disease measures. The ICF is key, even in our choice of outcome measures. The ICF has 3 levels. Impairment. When you are using ICF, outcome measures under impairment might include ROM measures, muscle strength, time walk tests, persistence measures. When you are using outcome measures on activity level, might include developmental tests for children, functional tests, activity skill assessment. When you are using outcome measure for participation, this may include, often it's about quality of life, assessment of life habits, assessment of participation and enjoyment, pediatric outcome data collection instrument in schools. Sometimes we do see situations, which is very common, where a research is being done, and this I have seen in many of our published articles, where they are talking about participation and quality of life, but the outcome measure that was used is muscle strengthening, which actually measures impairment. Strength of muscle has nothing to do with your level, with individual level of participation. You can have children with autism with muscle power 5, can run around and yet cannot participate in a single thing meaningfully. Muscle strength has nothing to do with participation. Yet, you see it, where they talk about quality of life, but the outcome measure that is being used measures impairment. This shouldn't be. But often it's because they don't use the IC in their work. So they misapply outcome measures. I'm going to move into practical so that I just want to chip in all this. Assessment tools, question to ask, what type of assessment do I want to do? Is it age appropriate for the population? Is it standardized? Again, a lot of my colleagues have said this. Does it have good reliability and validity? Is it practical to apply? How much energy will the assessment require the infant to expend if it's an infant? Are the findings of the assessment going to benefit the baby's care and well-being, depending on the circumstance you find yourself? So, assessment can be a criterion reference or non-reference test. A criterion reference have criteria or a minimum competence that must be reached to score an item or pass the test. For instance, a criterion reference contrasts the child's performance with the test rather than a population, while a norm reference test measures the performance in relation to a specific population, must consider the characteristics of reference population, as model development may vary across different social and ethnic populations. So you need to know whether you are using norm reference or criterion reference. Now I'm going, okay, real and potential impact of health, person, environment factors on assessment results. Key is the principles of handling and positioning. The ROM that I measured in standing is not the same thing that I'm going to measure when the patient is in non-weight bearing position. The context of inhibition is also, and facilitation is also important. There are positions that inhibit certain response, and there are positions that aggravate certain response. Assessment can be dynamic or static. Again, you are going to get different results, whether you use a dynamic assessment or a static assessment. Sensation, sensory, cognition, perceptual, and mental functions can really impact the assessment. All these can give rise to a Cushing syndrome, loss of verticality, or total neglect. But if one does not know how to identify all these problems in one, the patient might have a Cushing syndrome, and you diagnose it as loss of verticality or neglect, thereby managing the wrong person, running the wrong problem. So the pathology is also important, like ataxia 3+1, a postural disorder. All these are significant pathology. And how you assess each one of them decides the eventual outcome. Now, can you see the folder that I opened? Please, I want some response. Can you see the folder that I opened? Please unmute. Moderator, please allow them to unmute.
I've done that, sir.
Yes.
Right. Can you all see the folder that I opened?
Yes, sir.
Yes, sir.
Right.
Right.
I want us to look at this because I believe it's going to apply to everyone across board. And I don't want to give a specific case that I think I understand, but rather for us to look at agreements all over the world. What I'm opening for you, this is what you are going to see online, PIR Module 1 to 8, as published by the World Health Organization. So if you go on World Health Organization on cardiopulmonary assessment, sensory condition, malignant and neoplasms, this is what you are going to download. This is what I'm opening to you, which is also in 17, most disabling conditions. What I'm showing you on the screen is the foundation to what you see online. What do I mean by that? What you see online, you will never find what I'm opening for you online, because this is where all the food of what you see online is cooked, baked. So it's only the summary you will get, not the details. So what do I want to do here? We have cerebral palsy, we have Parkinson's disease, spinal cord injury, traumatic brain injury. So in terms of what we assess, how we plan intervention, which one among all these folders do you want me to go into for us to look at it? What WHO and the whole world come together to agree on what should be done. Like I said, this is not my own opinion. I only participate in the process. This is not my own personal opinion of what should be done, but rather this is a feed from all nations inside an Excel spreadsheet. So it's a summary inside an Excel spreadsheet or conclusion from all over the world that I'm opening here. We might not be able to go over everything. Tell me, which one do you want us to go into to look at it? I'm waiting, please.
Parkinson's disease, sir.
Parkinson's disease. Do we all agree with Parkinson's disease? So if there is no opposition or any other choice, so let's go inside Parkinson's disease. So here we go. I'm opening Parkinson's disease. Okay, I've opened it earlier and I think I did not close properly. I think I shut down my system. That is what happened without closing it properly. Okay, now here it is, assessment. What does the whole world agree on task level and assessment? For a Parkinson patient, we need to assess assessment of fall risk. Remember, task level is...
Go to my pause. That pause I took to market.
Mute yourself if you know you are talking to somebody outside this platform, please.
My earpiece.
So, assessment of fall risk, assessment of the environment, assessment of activities, assessment of participation, assessment of lifestyle risk factors, assessment of decision making, assessment of self-management. Why did I come here? I am very, very sure If I decide I'm going to use Parkinson's disease, please mute yourself. If you know you are talking to someone outside the workshop, we don't want to hear what you are discussing with somebody else. So you can see all these assessments. It is possible. Every one of you will be looking at me like what we are used to assessing, isn't it? We want to assess muscle range. But we are still going on the assessment of vision, assessment of hearing and vestibular functions, assessment of voice, speech, and language, assessment of swallowing, assessment of nutrition, assessment of sensory functions, assessment of bowel bladder management, assessment of sexual function, assessment of respiratory function, assessment of skin, assessment of cardiovascular functions, assessment of motor functions, assessment of fall risk, assessment of environment and activities and all that. Now, this is what WHO said we must assess when we are talking about Parkinson patient. Like I said, if I said, let's look at Parkinson, I'll probably go into range of motions, joint range, and we start all our fiddly faffy, shakaku that we all talk about, without going into the standard format of what we should do. But what I'm showing you right here is what we should do when you see attached layer 1. These are basic assessment that is mandatory in Parkinson's disease. How many of us who have gone inside it? Within all these assessments, each one of them have their own tools as well. This is how complex this today's workshop could be. In an advanced way, let's go to task layer 2. Now you look at assessment of cognitive functions, assessment of fatigue, which is advanced from those who can do assessment at task layer 1. So when the MRTD set up assessment and all that, people probably look at it like these are simple things because we are all used to our mindset of that barest minimum is comfortable. Because we don't even know beyond that what we are dealing with go far, far beyond what we used to do. But if we must call ourselves experts in rehabilitation, we must be able to know what we can do at task layer 1, which is the barest minimum, task layer 2, and task layer 3. How do you want to call ourselves experts if what everybody can do at task layer 1 is all what we can do? Some of us cannot even do all the assessment in task layer 1. Neither do we do it on a general day. How will we know the difference between that intern and that director of physiotherapy who does all assessment in task layer 1 and does not know how to go to task layer 2 or task layer 3? Each one of them have to. So task layer 2, you go into assessment of cognitive functions, fatigue, sleep disturbance, assessment of perceptual functions, assessment of mental health, screening for vision impairment. Remember, in task layer 1, you assess vision. You don't screen for vision. In task layer 2, there is screening for vision. If you can say this patient I think this patient has visual problem, then you move to task layer 2. Refer to the ophthalmologist. Refer to those who will not do screening for vision. Screening for hearing impairment, assessment of vestibular functions, assessment of cognitive functions of language, assessment of voice functions, assessment of speech functions. It's different from assessment for speech and language, assessment for voice functions, assessment for speech functions, then assessment of food selectivity and sensitivity. We are dealing with Parkinson patient. Assessment of nutritional status, assessment of pain, assessment of defecation, assessment of urination, assessment of lung function, assessment of respiratory muscles, assessment of heart functions, assessment of vascular functions, assessment of blood pressure functions, assessment of edema, assessment of movement functions, assessment of bones. Like I said, if I go into a case, I'm going to probably come, everybody will expect to come to movement and bone and joint and muscles. Then I will have misled all of you into believing in the same thing that is usual, rather than see beyond what we used to do. That skill and acquisition goes beyond what we are doing. Now, look at what we are talking about inside Parkinson. We have not talked about traumatic brain injury, what we need to assess. Schizophrenia, what we need to assess. Spinal cord injury, what we need to assess. They are also in task layer 1, task layer 2, task layer 3. So let me go into interventions.
We're talking about
I'm going to interventions now.
assessment.
Schizophrenia
Schizophrenia no be craze now. Where you from? Now disorder, brain disorder.
So brain disorder no be craze.
So cerebral person na craze now.
Schizophrenia na craze. You get department of people be craze.
What do you mean by cerebral palsy is craze? Because I can hear what you are saying. Are you a rehabilitation professional that you can say cerebral palsy na craze? I don't understand that person who is saying that. No, I'm really disappointed in the person that is saying that cerebral palsy na craze. And you can say it boldly on an MRTV platform where all professions are listening to you that cerebral palsy na craze. I mean, this is really shameful. Even if you have no good word to say, you can just mute yourself and keep quiet. That is more honorable than to say cerebral palsy na craze. I can't believe I'm hearing this from a professional. I can't believe it. I swear. I'm totally disappointed.
Hello, sir. Good afternoon.
Good afternoon.
Sorry, it's a non-medical person that was saying that, so I was trying to correct him.
Please exit him out of this place then.
He's not in the group.
So we're now going to assess. We have left assessment or what we need to assess, then interventions. So in task layer 1, energy conservation. We need to intervene for energy conservation. Why? The comment, Parkinson patients burn a lot of calories. Because of the way they move, the muscles are stiff, not relaxing. Burn a lot of calories. What do we do as physiotherapists or whoever? We load them inside the gym. We make them do lots of shakaku, body blasters. Whereas the first line of management in Parkinson is energy conservation. It's energy conservation. Think about it. Then we go into assessment and intervention in Parkinson. Like I said, if I didn't come into this book, it might look like, and John is talking about his view. Everything you see here is a consensus from all over the world. You will not see it online because it's not published online. You won't meet it online. It's not published. You will never find it. What you will get is what I've shown you, module 1 to 8, which basically gives a summary of what you need to do. They will never go into these details we are seeing now. So family and caregiver. psychosocial support, assistive products for indoor and outdoor mobility and transportation, assistive products for communication, assistive products for vision, assistive products for lymphatic and cardiovascular function, environmental health issues, environmental modification at home, environmental at school, environmental modification at workplace, nutrition intervention, manual therapy intervention, nerve system intervention, vascular and lymphatic, cardiorespiratory, communication intervention, swallow and salivation, sensory functions, cognitive intervention. You see the list and list of things that we need to do basically as task layer 1, not even in an advanced way. So, the list of things we would need to do in the intervention is as wide as what we need to do in our assessment. As an expert coming in at task layer 2, these are the things you need to intervene in Parkinson. And I'm going to the top again. What we need to do in our intervention in management of Parkinson patients. First, start with caregiver. What we need to do as caregiver, that's why you see everywhere you see those red tick, is summary of everybody's contribution all over the world. Caregiver training, incontinence, assistive products for pressure relief, share for shower and baths, fall detectors, personal emergency alarm system, handrails and grab bars, pill organizers, personal digital assistant, time management products, adapted seating equipment, assistive product for positioning, orthosis, prosthesis, portable ramps, rollators, crutches, elbow, canes. We can see all we need to intervene, and you can see that everyone presenting in this assessment since morning have a role to play in just this one case. If we go into the details of what we need to do, we can easily build a teamwork. See where all of us comes in together, where we all contribute to one another, where we all reinforce each other's practice. At the end of the day, it's a great value for patients. It's a great value for our practices, where every one of us win, and the patient win most. I will stop here for contributions and all that. I hope through this, I've been able to open the eyes and mind and the inner eye of those who are on ground now, because I know many people in the morning we have up to 93. Many people probably hesitate, thinking it's going to be repetitive, thinking we are going to be saying the same thing. Maybe some people did not even enroll for it, thinking it's the usual thing we are talking about. But what we are talking about is not the usual. Everything inside this document, I can say 99.9% of rehabilitation therapists don't do 40% of it in their practice. Yet they are not here to know that what they are doing is outdated. Thank you. So questions and contributions. We don't need to go into TBI, spinal cord injury, because what we are going to open is huge, really huge. Thank you, everyone. Can I close this page now?
Yes, sir.
Thank you, Lord. So, questions?
Hello, everyone. Hello. Can you hear me?
We can hear you.
Sir.
All right, okay. thank you for that wonderful and beautiful presentation, Dr. Anjorin. And really want to commend the way you're able to bring everything together, like harness all the perspective that has been expressed from individuals, professional practice lens. That's commendable. So it's not a question, but rather to still add my voice to what some of your closing remark. You know, like when I did my bit in the afternoon, the last line on the conclusion slide, for those of us that were part of it, was that these workshop or seminars, we want to call it, is a clarion call for us to learn and to relearn. And I'm not sure if Dr. Anjorin was actually there then when this was being said, and coming up again to re-emphasize the need for us to unlearn some of the things that we've been used to that had actually limited the effectiveness of our intervention and resultantly affecting the quality of service and quality of life that our patients are able to attain. So I really want to appreciate you for that. And again, as I said before, call our attention to the fact that there is a lot for us to unlearn in our traditional practice and embrace the global best practice in the interest of our patient and other service users. Thank you. That's just a few remarks I wanted to make, so not a question.
Thank you, sir. Thank you. I mean, we are all in this together. Sometimes lack of information makes people ignorant. But I always say that one thing I always say is the more I learn, the more I realize how much I don't know. And this humble me more. But the little one knows, if one sits down on it, it's easy to get arrogant with it that yes, I've known before. But it doesn't work like that. The template WHO developed for us to work effectively in management of all these cases is developed by all of us. Speech therapists, P&O, physiotherapists, all over the world. Everybody contributed and we agree on a consensus of what needs to be done. If this forms background to guidance of our training, people will know. But I can tell you, even if the registrar wants to use it, some people are going to complain. We already know what we are doing, even though they have not even seen. They have not seen what the registrar have seen. That everything we have been learning so far does not even address the depth we need to go into yet. But you are going to see people probably contain and challenging and say all sorts of things. For me, I always laugh that when ignorance thrives, the problem always is that people who are very loud always find a way to carry everybody along in ignorance, and this makes it difficult. So I'm going to look at some questions posted. Are there means to direct the question to him? Okay. Okay. Let me continue to go down. There's no question. Please exercise little more patience for the facilitator to rejoin. Okay. That's not my question. That is encouragement. Thank you. Yes, because okay. These are just questions, not for me, basically. Okay. Can you explain what profiling means during assessment? Can you use cervical conditions, lumbar conditions, and knee injuries for this comparison? Thank you. Okay. Auntie Dorothy really wants a whole workshop on profiling. What do I do to answer that question? Can you give me just a minute? I want to. The person who asked that question is a very big person to me. she used to be my mentor until she abandoned me and took me to motherless babies home. So just give me a minute so that I can respond to that. Please hold on. I think I'm going to be able to get something out of that, because if I don't, okay. Can you all see my screen? Can you all see my screen, please?
Yes, sir.
Okay.
Yes, sir, we could see it, sir.
Thank you. Thank you. So, these are not coming. You can go. There's nothing I can do. Maybe because Biayo told them I will be busy, other people will be coming, they decide if I join will not be available. She would have told them that I will be busy. Anyway, this is profiling. When we profile, we look at stable source. Hey, sorry. I was talking to some of my juniors here. So this is stable source. Where the stable source of the arm, foot, and pelvis. This is how you profile the patient's appearance. When they are standing in front of you, how are they resting? How is the position of the foot on ground? How is the position of the neck in the body? How do they place their foot? Right? Where do they put their weight? Is it medially or laterally? Right? So, profiling again, how is this patient standing? How is that patient walking? This, I've not touched the patient, but I get an idea of what I'm doing in terms of expected alignment and how far this patient has moved out of alignment. Again, profiling. This structural assessment, the patient's weight, where does the weight fall into? And where is the patient falling out? Again, profiling. Here we are. We have 3 postural patterns, right? If you can all see my screen, I and Johnny, I am in D. You can see my bottom is so flat, no muscle, nothing there. That's why I had to wear 2 boxers to hold my trouser in, because everything is flat. I don't have bum. And I hate sitting on a hard surface because I just don't have bum. So we can all assume all these postures. This part of our profiling. Here's the mistake all of us make. Someone in this posture have neck flexors that are weak, upper erector spinae that is weak, external oblique that is weak, anterior pelvic hip flexion, hamstring flexors, all of them weak in this particular posture pattern. While they have short, strong muscles of extensors, iliopsoas, long erector spine. The challenge physiotherapists have, which is, I mentioned a particular patient that has back problem at the age of 12, being managed by physiotherapists. And in 2 years, the cup angle have increased from 13 to 20. What happens? This is exact postural pattern this child comes up with. All the exercises that physiotherapists are giving to this child will worsen the problem because they don't even understand the profiling of this particular child. To know which group of muscles they should strengthen, which group of muscles they shouldn't work on, they end up giving ER tasks that will knock out the whole system to the point that that child don't have any comfortable position to lie on anymore. The spine, the back, the neck portion, sideline is not comfortable. Supine is not comfortable. Sitting is not comfortable. This child was placed on every dosage of drugs. It was this that brought the mother to my clinic, that somebody directed them to me, that this child cannot live on drugs forever. But physios have been seeing this child since 12 years old. and loading this child inside the gym to the point that even the angulation is increasing and they keep doing exactly the same thing over and over and over again. So, Auntie Dorothy, this is an example of profiling, why you need profiling. I hope I'm able to answer your question. Dorothy, answer me now. It's because of you I went out of the system. Or are we still quarreling? Please, any other question? I'm coming. I'm trying to go into I'm trying to see if I can enlarge it and go to questions again. Any other question that is here? Alignment is out of line. The knee get derailed, dysfunction. In situations where rehabilitation assessment has been conducted inaccurately or incompletely, what are the recommended practical steps for addressing the error, ensuring that the client receives appropriate intervention? Review the whole case. And we should develop that attitude of reviewing. I'm seeing a patient, I've done 8 sessions. I can't see any tangible change. I don't have to continue doing exactly the same thing over and over and over again. I need to review. So what I would say is that review. But when you review, do it the right way. Go through the steps you're supposed to use towards that review. Any other question? Please unmute yourself, everyone. Please unmute yourself. If you have any other question, let me know. If not, I can say thank you, everyone. Tell your colleagues, wherever you work at, there is more to practice than we are doing at the moment. There is more to practice than we are doing at the moment. When we learn more, we will be able to work with each other better. Then we will realize no man is an island. But if we keep ourselves inside our own cocoon, inside our own box we create for ourselves, we probably wouldn't get better. Because lack of knowledge contributes to our myopic view of what we need to do and how to achieve working as a team. Please, everyone, unmute yourself. If there is any question, even if it means going out of the system like I did now, I will do that to bring information. That is, as long as the information is on this laptop that I'm using at the moment, then I will dig it out. Except if it's in another laptop that is not the one that I'm using now. That's the only reason why I might not be able to go outside to get information. Again, there's something you guys need to know. If there is no question, let me go back to...
There is a question in the chat box.
Okay, please say it out. Okay.
It says, please, sir, what is the way forward for us? How do we access these WHO standardized assessment tools?
Who said that? What's the name?
Excellence Chidera.
Excellence Chidera. Chidera, you are very excellent. You want to steal WHO document? You want to steal WHO document? There's something that I say about these young ones. when they receive lectures, they feel like emptying your brain and just running away with it. That is the way they always approach issues of learning. And it's very encouraging, actually. I love it. Right? So, I'm coming. I need to show some things also to help us understand the need for us to change. I've done it before, and I'm going to do it again now. Draft package for cerebral palsy. And we have the mapping of RCA, but let's look at the draft package. Okay. This is the draft package for cerebral palsy, which we used as a template to create everything we want to do inside universal health coverage. Why did we use cerebral palsy? Cerebral palsy is the most complicated for us to handle. It's the most complicated that we find it difficult to agree on the template. So, what are we going to see there? Intervention for mental and cognitive functions in management of cerebral palsy. What are the equipment that we need to be produced, to be provided at every level? So assessment of cognitive function should happen at first level clinic, primary health care, general hospitals, teaching hospitals, right? At primary health care, government is supposed to provide computer and tablet software to assess cognitive functions, cognitive test equipment, toys and timer. Those are the equipment, basic equipment that is expected to be provided at all this level. But I'm not worried at general hospital, where we have a lot of professionals. Even at primary health care, a lot of our teaching hospitals and general hospitals don't have this equipment. They don't have access to it. But WHO is saying, provide it, even at primary health care level. You get what I'm trying to say here? What is this telling us? Assessment for vision, equipment, vision screening charts. Where should it be provided? At every level. Vision therapy, equipment, vision box, torchlight, reflective bulb, toys, plastic glasses for training vision. It will be provided even at primary health care. How many of us are taught in management of cerebral palsy? Or do we have access to any of this equipment that is going to be inside primary health care? And if you are not there inside primary health care, who is going to use them? If we stay in doing exactly what we have been doing, we will be working at a lower level than even inside the primary health care. So screening for hearing impairment should happen at primary health care, general hospitals, specialized level, even inside homes, communities, screening for hearing. It means people should be provided tools to be able to go inside communities to assess people for hearing impairment. Training in the use of hearing aids. Intervention for speech, language, and communication. All this is important for us to look at. But I'm trying to scroll further. for us to see something. Okay. Intervention for bowel and bladder management in cerebral palsy, sexual function, respiratory function, cardiovascular hematologic functions, motor functions and mobility. I always love to go here because this is where we are all used to. When you are treating a patient for mobility problem, the first thing, the first line of management is assessment of bone structure, bone integrity. How many of us assess for bone integrity before ambulating? This should be done not at primary health care, at general hospitals and teaching hospitals. Weight-bearing exercises should be done even at primary health care. Equipment that should be provided, harness, adapted bicycles. Assessment of mobility of joint functions. Goniometer, measuring tape. It should be at primary health care, general hospitals, and general and teaching hospitals. What are we saying here? People who are not professionals will have access to goniometer and measuring tape. So if you look at goniometer as a tool that you are an expert in goniometer, you won't be that expert anymore. If you don't go inside the previous document, where you can do more, assess more, and up your game, up your skill, you probably be working at a very low level and compete with people who are non-professionals. So bone health, mobility of joint functions, stability of joint functions, muscle power functions, muscle tone functions, muscle stiffness, movement functions, gait pattern functions and walking. Many of us don't understand that movement function is different from gait pattern. Muscle stiffness is different from muscle tone functions. All this I'm trying to show you is for us to realize times have changed. We all need to up our game. We all need to up our practice. We won't be able to practice for long the way we are practicing. Unfortunately, a lot of people are not in that awareness. Right. I think we should be rounding up now. I hope everybody enjoy my time with you, because I actually came to enjoy myself. If you didn't enjoy yourself, just let me know. If you enjoy yourself, we can say good night, everyone. Please, sir, what is the way forward for us? How do we assess WHO standardized document? Excellence, I've told you, you are a thief. You are a professional thief, not the local thief. You are a professional thief. Chidera. But I love you for that. So any other question? Chidera is the only person that is giving me concern, and I don't know how to help her. Honestly, I don't know. Because the document that I opened is not available online. Okay, go ahead, please.
Okay, good evening, sir. I'm actually excellent, Chidera.
Oh, okay. Let me see your face. I'm coming. Let me see your face. Let me see your face so that I will identify you anywhere I see you. I want to see that face.
Sir.
No worry. Where is excellent? She there. Where is she?
Okay, sir. My question, it just came out.
Where are you?
Okay, see my face, sir. Wow.
Okay. It's only showing E. I want to see your face so that I'll run for cover anywhere I see you.
No, sir, I'm not a thief, sir. Okay, I just want to explain my concern.
Okay.
Okay.
I'm listening.
Now, I participated in this workshop. I don't know. Okay, let me just talk for myself. We all have an expectation to better our practice, to get see what we can learn to, give better treatment to our patients. And yes, and having been part of the session that just concluded, I find your own very educative, very insightful, very up to date. Okay. And again, I was thinking, how can this be known by everybody? Because the things that you said are very, very deep. Like I personally, I didn't know of this. And I've been practicing with the little knowledge, I got from school and the one that I also get while enrolling for the CPD programs. So I was not thinking, what is the way forward? How, because the truth of the matter is the patients really need this. Okay, our patients really need this, and we just can't be doing the same thing we do year in, year out, over and over again, which is not giving us the maximum results. So I was just thinking, is there a way to plan a curriculum, okay, even to affect the undergraduates or even the postgraduates, anyhow, so that this can be passed across and we will learn and do better. So that just from that point of view, where I'm coming from.
Yeah, and now this document, the one in my hand, is the expert document. It's not what you see online. Even if I try to share it online, it will be logged. That I'm putting it on an internet platform. I told you that I have to shut my system down because it refused to open and it refused to scroll earlier. Because automatically, immediately I'm online. It's coded in such a way they will know that material. Now, we really want to teach it and we want to use it to focus. But it is only in workshops like this that we have opportunity to let people know that what we are dealing with is much more than what we are presently doing. A lot of us are used to the way we used to run workshops, even including myself. When people ask me to come and participate workshops, because of the background of what I do, I felt very awkward. But how can we bring this down? We can break it down in such a way that we can teach task level 1, task level 2, task level 3. But it's something that we have to get there in a gradual way because many people don't know. Now, if we advertise for a workshop and we want to go into this, because it's not management of Parkinson per se or management of dementia per se, people are going to wonder, what does this information tells us? But the information is telling us for assessment for risk, for fall risk, for example, it's telling me there's a document inside it that tells us what we need to do inside fall assessment, which is a consensus. I hope you get me. For everywhere you see that there is an information about what we need to do in the situation and how we need to manage it in the situations, which we can actually talk about, discuss, and all that. After this workshop, I will call the registrar again. For those who have participated in previous workshop and are aware of this, if they are ready to subscribe, let's start breaking down the information for them in a way that I will not flout WHO regulation. At the same time, I will be able to pass the information across in a meaningful way that people would be able to use them. Funnily enough, like I said, most of the time, the younger ones have passion to learn, not the experienced physiotherapists. There will always be problems there. Because when Chidera learn new ways of to do things beyond average, because what we call average is task level 1. Even what we see in dementia in task level 1, many of us cannot see dementia case and know what to assess in dementia in terms of their lifestyle. Oh, decision-making capacity. How do you assess decision-making in dementia and be able to get to the bottom of the problem? Now, Chidera wants to go from task level 1 to task layer 2. What if Chidera has an HOD or a boss who frustrates everything she's trying to do? No, don't bring that into my clinic. Because they don't know and they don't want to know. It's a major problem. I've been there. I'm a well-experienced physiotherapist, so I know what is going on. This is the problem again. So why the young ones want to learn? The challenge of where to put it into practice or when to apply it. Because if you are not the boss in your clinic and you learn the right thing, the likelihood of being frustrated to even apply what you learn can come into play. I'm not saying this to discourage you. I'm saying this to be aware that yes, you will learn this, but there's a lot of work to do. This should not stop you from learning better, doing better for your own good, not because you want to impress anyone. Because when you know what to do and you can move a patient that is being seen by someone elsewhere, the day they come in contact with you, you will go higher than what they have experienced. They will compare you with those who have been seeing them earlier. And they will see the difference between you and those who have been handling them for months. Because you will be able to look at what they have not looked at. You'll be able to address and treat the patient better, more holistic, addressing the problem rather than doing the same thing over and over and over again and not knowing what needs to do. It's something that you can do. And I hope this has answered some of your questions. But between you and me, I can do as much as I can to support you. But MRTB also needs to come forward more in terms of what we need to do, what we need to learn, and all that. A lot of this comes up inside the clinical pathway, but it can also come up in workshops in a way that we can work on task layers. So if we work on those task layers, maybe you see a workshop that talk about task layers in dementia or task layers in Parkinson, just know it is this document we are delving into. I hope you get me. That it is this document we are delving into to be able to share those knowledge in a way that is meaningful and you can take it forward. Does that answer your question, Chidera? Chidera,
Yes, sir.
does that answer the question? Okay, thank you. Still,
Yes,
I still want
sir.
to see your
Thank
face.
you so much, sir.
I still want to see your
You want to
face.
see my face?
Yes, I still want to. Don't worry, I won't fall. Chidera, don't worry, I won't fall.
You won't do what?
I won't fall. I won't fall for your beautiful face. I just want to see.
No, sir, I'm not fine, sir. My face is not fine.
It doesn't matter. That's why I said, I mean, beauty is in the eye of the beholder. Okay, I want to fall. Let me see your face. And this one is not beautiful. Please, everybody, go fund me. I want to post there. I'm launching GoFundMe through MIT. Please, excellence funding, please.